Good evening to all of you guys. I've been reading your messages on the chat, so don't feel I was not here. I was seeing everything you were chatting. App said this said that, but I was told to start at 5, so that's when I will. Since today is the first day and your first time with me, probably a lot of new names, new faces. I will tell you how the class is going to be conducted. So, unfortunately, you have only 5 sessions with me. I would have liked a little bit more because surgery is a very big subject. So rest assured, every class will at least be from 5 to 10 or even longer, little bit. For tomorrow, I have requested them to allow me to start sooner. Okay, so I have requested because it's a Sunday that we can start earlier, maybe by 3 is what I have requested. If they approve, you will get the message. Okay, so that's how it is going to be. And our system is going to be very similar if you have the RR notes or the quick revision notes. Very similar to that. We first do GIT, then hepatobiliary, then other super specialties, trauma, urology. We will go about it like that. And hopefully, most of the IMP things we should be able to cover. Okay. I urge you to please avoid unnecessary comments and unnecessary interruptions. Okay? If you feel at any stage voice is sounding less or there is a lag or whatever, please refresh because it will be at your end most probably. And any queries regarding PDF notes, this note, that note, you can connect with the team. So before every class, I send them the notes. After every class, I send them the annotated notes. So please ask them for it, not me. It's a request. Let my job here be to teach you. Surgery is a very important subject for FMG. I'll share experiences of your seniors who cleared FMG in Jan and what they told me. Okay. But yeah, please extract the maximum. I will solve your individual queries also along the way. And of course, you can ask me on Telegram or Instagram. On Telegram, I keep posting MCQs every other day. And on Instagram, I post reels and easier mnemonics, easy things to remember, those kind of things, if you wish to follow. But definitely, 5 days you are with me and one END day, extract the maximum you can because a subject like surgery, if you know well, it will save you. This mission 200 will become a reality. Definitely 150 will become a reality, which should be your target. Yeah, it's not that difficult. No, I will tell you how to study. And please don't say use English because there are a lot of only English speaking people also. I have no problem. मुझे तो हिंदी is my first language. I am more comfortable in Hindi. आप ऐप पे मेरे हिंदी videos देखोगे, they are better than English videos, honestly. But we have to be considerate of everyone. So please don't mind that. No English, only English. ठीक है? बाकी बीच बीच में spontaneously थोड़ी थोड़ी हिंदी आ जाएगी. But the academic part will be English. And I trust you had many subjects done already. So I hope your experience so far has been good. And I hope to continue the same way. Please cooperate. These sessions are for you. Please don't indulge in any disruptive behavior. Rhythm break करने वाली चीजें मत करना. Yeah. और मेरी handwriting mind मत करना. Because over time my hand will get tired. So वो mind मत करना. So today we will do half of GIT and tomorrow we will start a little early if possible, or we will do the other half of GIT and maybe do some short topics from general surgery. That's the plan for tomorrow. ऐसे करेंगे और Monday को hepatobiliary करेंगे. So let's start. I have also put questions which have come in the FMG entrances over the years, so you will get an idea क्या क्या topics आते हैं. तो आपको IMP topic समझ में आने चाहिए. Every topic that I am going to touch upon is IMP. तो ऐसा मैं कुछ भी नहीं पढ़ाऊंगा जो unnecessary है. इतना तो आपको आना ही चाहिए. Every topic you should use that I'm going to teach you. At the end, how to revise, you have two choices. One is only use these annotated PDFs or make notes as we go, or use the RR notes and keep them as your base. एक base होना जरूरी है पढ़ने के लिए. Either it should be your RR notes or it should be what you write or from the class over here. ठीक है? तो ये base होगा. उसके ऊपर जो भी आप पढ़ोगे, whatever extra you study from QBank or GTs, or if you watch the main videos, I don't think you need to watch main videos. You don't have so much time. But if you do anything else, add it to those base notes. तो एक ही जगह पे पूरा सर्जरी होना चाहिए. ठीक है. Don't keep it in 10 places with hundreds of PDFs. Don't do it like that. फायदा नहीं है, सब भूल जाओगे. या हमारे क्लास के नोट्स यूज करो या आर नोट्स यूज करो, दोनों में से कोई भी एक एंड ऐड टू इट. Okay, so let's start. So we will go in the system of esophagus, stomach, small bowel, and so on and so forth in GIT. So today the plan is esophagus, stomach, small bowel, itna to karenge. Appendix macros. Half of GIT should be done today. Okay. If there is anything which you don't understand, I will try to explain it again. But still, avoid interruptions. If you are attentive, आपको सब समझ में आएगा. खाली ध्यान देना है. क्लास थोड़ी लंबी होती है, I understand. पर अब जरूरत आपकी है तो आपको करना है. बीच में अगर थक गए, if you zone out a bit, then get up, have some coffee, go to the washroom, do some YouTube or Instagram. See my Instagram profile, it's quite nice, and come back. If you miss 4-5 minutes, it's okay. Okay, and I will give you 2 breaks in between. One break at 6:30 and one break at around 8 o'clock, 8:15 dinner break. So 2 breaks you will get. Okay, and I'm sure you had so many classes के आपको अभी idea हो गई होगी how classes go, because you had classes much longer than the class I'm going to take, है ना? So that's the plan. Today we will keep 5 to 10, but tomorrow I will try to start earlier. I have requested them for 3 o'clock. So maybe we can cover more tomorrow. Maybe go from 3 to 9 if possible, because it's Sunday. Yeah. So please watch for that update. It will come on your group. So let's start with esophagus. And the first and the most important topic you will study in esophagus are what are called as the motility disorders. Esophagus has peristalsis. So when you eat food, it gets pushed down because of the peristalsis. Whenever this peristalsis has a fault, you will have a motility problem. What is the most common? So MCQ, most common motility disorder. What is the answer? Quickly tell if you know the answer. Most common motility disorder, achalasia or achalasia cardia. Pranav is saying achalasia cardia. Is it achalasia cardia or achalasia? Okay. So you will realize along the way what is the correct answer. For now, I will write achalasia. The word achalasia means failure to relax. Like how you guys don't relax in life. Like I have just started teaching and already you're bombarding with comments which are not relevant here. Same way, if you don't relax, you become very rigid. So don't do that. If you have a failure to relaxation, your mind will become achalasia. So there will be a failure to relaxation. But what is going to fail to relax? That is going to be the lower esophageal sphincter, LES. When I see the esophagus, so thoda I will tell you about the anatomy of everything that we do. When you see the esophagus, this lower part here, there is a sphincter. It's called LES, lower esophageal sphincter. It has a little tone. If the tone is very tight and if it will not open, then what will happen is when you will eat food, it will not pass. And if it will not pass, you will get dysphagia. So this is simple meaning of achalasia. It is a failure to relaxation of lower esophageal sphincter. But let me tell you the more important thing. This is not that important. The second problem that you see in achalasia is more important. And that is there will be ineffective peristalsis. Okay, there will be ineffective peristalsis. This lot of people don't realize. Everybody will say achalasia, failure to relax. But it's not just failure to relax. There has to be ineffective peristalsis. Ineffective peristalsis means what? I have these nerves which supply the esophagus. What are these nerves called? They are branches of vagus. Yeah, they are branches of vagus. They are called the myenteric plexus. So they are branches of the vagus. Myenteric plexus. Okay, they come from vagus. My means muscle. Enteric means inside the muscle. So they supply the muscle. In my GIT, whenever I say vagus, what is the job of the vagus? The job of the vagus is to promote peristalsis. So anywhere in the GIT, when you say a vagal innervation, what will vagus do? It will promote peristalsis and it will open the sphincters. Obviously, sphincter has to open. If the sphincters don't open, how will food pass? So there has to be peristalsis and the sphincter should open. In this disease, in achalasia, there is problem in these two because the myenteric plexus is missing or it is reduced. So the main problem in achalasia is the myenteric plexus is reduced or the parasympathetic is reduced. So if it is reduced, lower part it is absent. So the sphincter will never open. Upper part it is reduced. So the peristalsis will be weak. This is achalasia. Whenever you talk about achalasia, both these things have to be there. Okay, both these things have to be there. Peristalsis should be weak and LES should be tight. Like how your mind gets tight, not anything else. Same way, these two problems have to be there. Both are effect of loss of parasympathetic. ठीक है, आगे बात समझ में इतना ही ध्यान में रखना है. If you understood this, achalasia is piece of cake. बाकी सब easy है. Why does someone get achalasia? What is the etiology of achalasia? It is normally seen in the younger population, young like me, okay, not young like you. You are much younger. It is normally seen in 30 to 50 years, usually females. And there is one parasite which is called trypanosomiasis. You may have heard of it. Trypanosomiasis linked to this disease, Chagas disease. Suna hoga aapne, which causes sleeping sickness. So it is hypothetically involved. Herpes simplex virus. This was given in older books. It's not given in Bailey anymore. These are some of the reasons for which these ganglia are lost. And because they are lost, this myenteric plexus or the vagus or the parasympathetic, because it is lost, these two problems will be there. Now, how is the person present clinically? What should you expect? The most important clinical feature will be a dysphagia. So a young person like me, not like you, little older than you, young like me, if he gets dysphagia, and the dysphagia initially is more to liquids. Okay, initially liquids more than solids. Then you will think of achalasia. If the person is 60, 65, much older than me, senior citizen, and he gets dysphagia, what will you think? Very good, excellent, you will think of cancer. So in the exam, the question is going to be either a young female or elderly male with dysphagia. If it's young female, think of achalasia. If it's elderly male, it will be C. esophagus. Okay. The volume is low on your end. It's not low on my end because I checked the speakers. Okay. So please don't keep saying that. Just refresh and join again or increase the volume there. Initially, liquid. More than solid. You can predict the word, no? अगर यहाँ पर solid है, तो यहाँ पर liquid ही होगा. I mean, come on. So first problem will be dysphagia. Second problem is he will say when he lies down, food comes back into his throat. He gets regurgitation. That is the second problem. So one problem is dysphagia. Other problem is regurgitation. Because of dysphagia, regurgitation, food is getting stuck. He also has weight loss. Okay, he will also suffer from weight loss. These three together is what is called as triad of achalasia. Dysphagia, regurgitation, weight loss. ठीक है, आगे बात समझ में. Basically, any patient who says when I eat food and the food gets stuck, it means it is dysphagia. Why more for liquids? It is a feature of motility disorders. Whenever there is a problem in the motility, liquids will not pass. Solid food will find its way because it will push the sphincter open. Liquids will not have that power. So liquids will get stuck first. What will you do first? Investigation. Patient comes with dysphagia. What do you do first? So yeah, it will be always whenever you are talking about any disease in upper GIT, esophagus, stomach, duodenum, the first will always be upper GI. Barium meal is a thing of past. Nobody does barium meal anymore. You are going to do upper GI endoscopy. And what will you see in upper GI endoscopy, or what is the purpose? Will it tell you that there is achalasia? Will it tell you that it is achalasia? So it will not tell you achalasia. No, it is not the diagnostic test. It will only say that the LES area is tight. So why should I do upper GI endoscopy? क्यों करूं मैं? क्या मिलेगा मुझे करके? Why should I even do it? Why not just do manometry? Very good, Laddu bhai. Excellent, Rupak. I want to rule out any growth. I want to rule out, is there a cancer? Because it's not necessary that the person, if he's young, can only have achalasia. If he's 45, 50, he can have any of the two. Which is why now think like a doctor, especially for MCQs. First, what you're going to do whenever esophagus or stomach comes in the way is going to be upper GI endoscopy. This question came in FMG. Okay, this one, January 1. So if upper GI scopy says LES is tight, but there is no mass, the next step, then you will do the investigation of choice. That is going to be esophageal manometry. Okay, that is going to be esophageal manometry. It was so simple. If your understanding of a topic is correct, how much ever they twist it, how much ever, you will never make a mistake. Okay, understand the concept of these kind of topics. फिर क्या होगा, आपको revision में भी ज़्यादा time नहीं लगेगा. It will all be clear in your mind. So you are going to do esophageal manometry. What do I see on manometry? How it is done, you don't need to know. This is how it looks. Just have a good look at it, because they can ask you image. Hard, you must have never seen a picture like this. So how do you know it is manometry? Whenever they give you any image, try to see how the scale is. Okay, and images come like this. They are not clear. They are just like this. I purposely put this image. So you can read some numbers here: 10, 20, 30, 40, 50, 100, 120, 140, 160, 180. What are these numbers? You can see over here. This is mm of Hg, or millimeters of mercury. If you see millimeter of mercury, that means it is a manometer. Okay, don't try to get an idea from this. This is a little hard. I mean, come on, we don't do this regularly. So what you should do when you are given an image which you can't understand, नहीं समझ में आ रहा क्या हो रहा, see the scale. Scale में answer मिल जाएगा. Here the scale is mm of Hg, so your answer is going to be manometry. Why do I do manometry? I want to show two things. One, I want to show it is tight LES. Means the pressure is very high. So high pressure at LES. And the second thing that I want to see is that there is weak or ineffective peristalsis. Ineffective peristalsis. First, simple. See, you can also diagnose achalasia now. It's so simple. Common sense answer. Yeah. Yes, there is a classification for this, but I don't think you need to know. There are 3 types of achalasias. So if you want to know the types of achalasia, there is a classification which is called Chicago classification, but I would not tell you to worry about it at this stage. Okay, पहले ये तो पता चले manometry करनी, फिर सोचना Chicago. But yeah, that's what you're going to do. Right. So now I know, yes, achalasia. What do I do next? And in olden days, when this manometry and all was not there, how would they diagnose? They would do this. What is this test? Olden days, आजकल नहीं करते हैं. How to know about peristalsis? The manometry report will tell you the peristalsis. So it will tell you that when you drink water in the manometry, the water is not passing. So this image that you see, whenever you see something so white, that means contrast is given. So if a contrast is given for esophagus, that is going to be barium swallow. Okay, that is going to be barium swallow. What is this image showing you? Bird beak. Yeah, you are imagining bird's beak. Don't say bird beak. Bird beak is more imaginary. You know, if you like birds, this is not bird beak. What you should see is this esophagus over here is dilated. So you see dilated esophagus. Then what you see, this part is very narrow because the LES is tight. But this transition from narrow to tight or from distended to narrow, this transition is happening very gradually. It's not happening very fast. Gradual narrowing. So when you come for class, I will not start ragging you from the start. First, I will be nice. I will be motivational. You will get to know me. And then you will realize, sir is a surgeon. Surgeons are never sweet people. Surgeons are always very rude. So slowly, I will start grilling you. And you will realize when I start grilling you properly. Same way, achalasia is going to be gradual. So I am your life's achalasia. Think of it like that. I am not cancer. I will tell you what cancer is. So on barium swallow, you will see dilated esophagus with smooth tapering. Okay, you should hunt for smooth tapering, and I will show you how cancer looks when you do cancer. This appearance is called as bird beak appearance. Okay, in Bailey, it is also called rat tail, but then rat tail is a dangerous word. Rat tail can be used for cancer also. Use both ways. So better to stick to gradual narrowing or smooth tapering. I think that's a safer terminology. Okay, instead of worrying about bird beak, rat tail. Who are we to imagine beaks of bird? Bird तो कभी life में देखा नहीं होगा. मुंबई में तो नहीं है. I don't see birds in Mumbai. Who will survive here, right? So this is what we'll tell you. It is achalasia in the past, not anymore. Anyways, now you have achalasia diagnosed. What are you going to do? My question is, do you have to treat every patient of achalasia? जरूरी है क्या? Every time you are given a surgical disease, you should ask this question first. Do I have to treat it? If yes, do I have to do surgery? Two questions you should always ask yourself, then you get the MCQ answer. So do I have to treat it? You're saying yes, why? Why do I have to treat it? Excellent, Shubh, excellent. I hope you are not answering from the notes. I hope you are answering by awareness. So all patients have to be treated. And how are you going to treat? That's immaterial. But why all have to be treated? It's a pre-malignant condition. Absolutely right. What malignancy can happen? You can get squamous cell carcinoma of esophagus, MCQ. Okay. It is a pre-malignant condition for squamous cell carcinoma. Where will I get it? Just this part. This is where I will get it. Just proximal to the LES. जहाँ पर dilate होता है ना, वहाँ पर होती है. Now, how do I treat it? Various ways of treating. I can give a medical management. It's possible. There can be medical managements. So I can give some muscle relaxants. It will open the LES. So I can give calcium channel blockers or nitroglycerin. Or I can inject Botox. You know what is Botox? जो लोग face पे कराते हैं, so that these wrinkles go away. I don't have wrinkles yet, but it's not because I've done Botox. So Botox can be put in the LES यहाँ पर. You can inject Botox. So fine, it will relax the LES. But all this is temporary. If you want a little better result, you can do endoscopic dilation. So you can put an endoscope and you can dilate the LES. But if you notice, they are not tackling the main problem. The problem is not just LES. Problem is peristalsis. So currently, the treatment of choice is going to be surgery. That is this surgery. This is called as Heller's. What is the full name? Heller's what? Myotomy or cardiomyotomy? Is it achalasia cardia? And is it Heller's cardiomyotomy? Or just myotomy? Is it achalasia cardia or is it only achalasia? I earlier wrote achalasia. So two things. First is achalasia is not achalasia cardia. Cardia is, you know what? This part. This is cardia. Just below the esophagus. जो stomach की upper part होती है ना, that is cardia. There is no disease in the cardia. So achalasia cardia is a misnomer. ये गलत नाम है. Okay, ये गलत नाम. If you read surgery books of today, they will call it achalasia. They will not call it achalasia cardia. Cardia तो ठीक है. Why should you call it achalasia cardia? But myotomy is cardiomyotomy because as you see in the image, the myotomy will also go to the cardia. Myo means muscle. Otomy means cut. So what you are doing in cardiomyotomy, you are simply cutting the muscle. So if your mind is very rigid, then what will I do? I will shout at you. I will motivate you. I will make you give tests so that your mind opens up. I will give you change your perspective. So basically, I'm cutting the muscles in your mind which are restricting it. Same way, in achalasia cardia or in achalasia, I will cut the muscles. Obviously, this is surgically done, but I cut it in the lower esophagus. So one area where I cut the muscle is lower esophagus. How much lower esophagus? About 6 to 7 centimeters. ये number मालूम होना चाहिए. Okay. And I also cut the cardia, upper stomach. How much? 2 to 2.5 centimeters. This part. So myotomy is cardiomyotomy, but achalasia is not achalasia cardia. Why cut the stomach? Because if you don't go onto the stomach, you don't get a clear margin. Like how in cancer we always cut a little extra. Same way over here, cut a little extra just to be sure. Because if you cut the LES little less, then that part will remain tight. Person will say, doctor, you operated me. I am still having dysphagia. And then you will say, I will have to reoperate. Patient will say, ek patient, do surgery. So you have to do a complete job. All right, you have to do a complete job. So this is 2 to 2.5 centimeters. Cardiac, the cardia part. The esophagus part, 6 to 7 centimeters, almost double. Esophagus is the main area of the problem. ये थोड़ा extra, this 2 centimeters your margin of resection. ऐसा समझ लो, cancer में करते हैं. Nowadays, there is an alternate to this that is called as POEM procedure. What is POEM? POEM is peroral endoscopic myotomy. Okay, POEM is peroral endoscopic myotomy. It's not really a surgery. Surgery, it is done by the gastroenterologist. It's not done by a surgeon like me. Gastroenterologist will do it. And this is preferred if you have type 3 achalasia. Okay, don't worry about what is type 3 achalasia, but just accept for MCQ, this is preferred if it is achalasia type 3. Otherwise, in principle, for achalasia, treatment is Heller's-Mann. Okay, but in this special type of type 3 achalasia, POEM is better. Okay, ये हो गया achalasia. Any problem with achalasia? I hope not. You should be able to solve any question and every question, like this question which came in FMG Jan. So see, don't focus on the answer. I'm sure you know the answer because we have just done it. Focus on the question. 30-year-old patient. Okay, means younger than me. Difficulty in swallowing for both solids and liquids. And this image is done. And what do you see nicely in this image? You are going to see smooth taper. Okay, smooth tapering. Now don't tell me this looks like the beak of a bird. मेरे को तो ये bird beak नहीं लग रही है. मेरे को तो ये छिपकली की पूंछ लग रही है. It looks like the tail of a lizard. So bird beak, I would not call it. What would I call it? I would say smooth taper. Right. So answer is going to be achalasia. Right. In corkscrew esophagus, just out of discussion sake, the esophagus looks like this in corkscrew. It's another motility disorder. It is also called as diffuse esophageal spasm. That is the name of the disorder, diffuse esophageal spasm, in which you get a corkscrew esophagus. Okay? Simple. So in one topic, you got so many MCQs. POEM is for type 3. For other types, it is Heller's. Okay. Now come to this Senker's diverticulum. First, you need to know what is a diverticulum. Why am I teaching it here? Diverticulum simply means there should be an outpouching. Okay, there should be an outpouching. Like when I'm taking class, you are all listening to me, asking normal things. But if someone does something abnormal, he will stand out. लाइक कोई एक ही चीज पकड़ के बैठा है. He is saying the same thing. Voice is not clear. Voice is not clear. Voice is not clear. Then he stands out. The other people will also say, please keep quiet, guys. Same way over here. If someone is outspoken, there is an outpouching. That is a diverticle. So a part of the wall bulges out. Like how you have aneurysm in artery. Artery में aneurysm होती है ना. If you have an artery, if it bulges out like this, you will call it aneurysm. Same way, intestine may you get diverticle. So diverticulum is in context of intestine. Diverticulum are of two types. Either they are true diverticulum. True means it will have all layers of bowel. You know the layers of bowel? Mucosa, submucosa, muscularis, serosa. The whole bowel outpouches. That is a true diverticulum. True diverticuli are very less. They are not so common. Any example of a true diverticulum that you know? You may have studied in your life, maybe in anatomy. Any true diverticulum you know? Gulti Band. Yes, very good. Rupak, Asta, excellent. Meckel's diverticulum, true diverticulum. Full bowel wall is outpouching. Perfect. You can get false diverticulum. In false diverticuli, only mucosa outpouches. तो क्या होता है ना, in the bowel you have serosa, muscularis. When the muscle will get stretched, अगर muscle फैल गई, then the mucosa goes out. So if the muscle in the bowel wall gets stretched out, then the mucosa inside will start going out like this. This is a mucosal diverticle, a false diverticle. This will happen when there is high pressure inside. So when there is very high pressure inside the bowel, it will push the mucosa out. So false diverticuli are seen in scenarios where the pressure is very high inside the bowel. Any other diverticulum you know in the bowel because of high pressure? One is Zenker's. Any other you know? Which happens because of high pressure and it's only mucosa that outpouches. It is in the other side of the GIT. No, hemorrhoid is not bowel. Hemorrhoid are blood vessels. Epiphrenic sigmoid diverticuli. In sigmoid colon, also you get diverticuli. Same way. If I am very constipated, आप लोगों को नहीं होगा इस क्लास के बाद, आप लोग तो भागोगे वॉशरूम में. But if there is constipation, then only the mucosa and the sigmoid colon outpouches. That is sigmoid diverticuli. So here what will happen is, we'll talk about this. We'll talk about Zenker's diverticle. What will happen in Zenker's diverticle? It is a false diverticle. It happens because of high pressure in pharynx. Okay, it is because of high pressure in pharynx. High pressure in pharynx means what? You see this muscle over here. Okay, this is in the pharynx, oropharynx, and this is the esophagus. So just above the esophagus, you have this muscle. What is the name of this muscle? What is the name of this muscle? Just above the cricopharynx. Nishant, hernia we will do tomorrow. That time I will tell you. Hernia is not the same. Don't worry about it. No, it's not thyropharyngeus. What is this muscle above the esophagus? There is a muscle above the esophagus which is called inferior constrictor. Okay, it is called inferior constrictor, which has two fibers. One fiber are called thyropharyngeus and other fibers are called cricopharyngeus. So they are two parts of the same muscle. Now you can see over here, these fibers, thyropharyngeus. These fibers, cricopharyngeus. So oblique fibers, thyropharyngeus, horizontal fibers, cricopharyngeus. Between these two fibers, there is a triangular space, a weak space, where there is no muscle. Okay, where there is no muscle. So the problem is, these fibers are not continuous. Some are like this, some are like this. In between, you have the space. It is called as Killian's dehiscence. So in between these two fibers, you have a weak area, which is called Killian's dehiscence. It is there in all of us. Sometimes when the pressure in that area is very high, the mucosa will start coming out like this. So only mucosa is going out onto the serosa. It is going through the muscle. Someone was asking before, no, how can only mucosa go? It is going because the muscle is getting split, so it is going between the muscle. It has a serosal covering, no doubt. So it is mucosa and serosa. There is no muscle. It is going in between them. वो बीच से जा रहा है. So this Killian's dehiscence is the area where the mucosa will outpouch, and this will give you the Zenker's diverticulum. So what is Zenker's diverticulum? It is a diverticulum through the Killian's dehiscence. What type of diverticulum? Mucosal diverticulum, false diverticulum. ठीक है? ज्यादा जोर से चिल्लाने से कुछ और होता है, वो लैरिंग्स में होता है. Anybody knows ज्यादा जोर से चिल्लाने से लैरिंग्स में क्या होता है? Anurag's question. Your ENT class is done क्या? नहीं, nodule नहीं. Nodule is different. Something outpouches. It's called laryngocelia. Excellent. Laryngocele. It is seen in जो trumpet बजाते हैं ना, पुपली, उनको होती है laryngocele. It's not a surgical disease. They are trumpet blower. Excellent. See, you know so much. You just have to use your energies in the correct way. If you use your energies in the correct way, mission 200 easy. Okay. Then next year you will be, after 6 months you will be taking interview with me if you want. No, you won't want to take with me. I know. You will want to take it with fancier people, but option is there. Option is open. लेना है तो ले सकते. ठीक है. Anyways, so the mucosa outpouches through the Killian's dehiscence. Where is the Killian's dehiscence? It is between the thyropharyngeus, cricopharyngeus. Both of these muscles are a part of inferior constrictor muscle. So it's not really an esophageal diverticulum. It's just above the esophagus. ये है ना esophagus, तो यहाँ से शुरू. This is esophagus. It is just above it, and it is posterior. This space is on the back side, so it will not come like a neck swelling. It is on the back side, not on the front side. Anyways, what's the big deal? Okay, so just above the esophagus, you have a diverticulum. So what? क्या बड़ी बात है उसमें? ऐसे diverticulum होने से क्या खास बात है? So there is a little mucosa. Mucosa ही तो है. Very good. Excellent, 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 brilliant. So the problem is when I eat food, most of the food goes in the esophagus. Some of the food will go into the diverticulum. If you are unlucky, it will go in the diverticulum. So the problem is this food gets collected. Some of you wrote correctly. Clinically, what will the person present with? He will say, when I go to bed, normally food will collect, he won't come to know. But when he lies down, सोने पर, typically at night, when he lies down, yeah, ये word, DOW and down. When he lies down, the food comes in his throat, so he gets regurgitation. तो जो भी खाना उसने खाया है lunch में या dinner में, लेटने पर he will say food comes into my throat, regurgitation. You know, some animals can intentionally bring their food into the throat. You know what that is? Like cows and all, cows and bulls, they can bring food back up. Yeah. What is that called? Yeah, ruminants. Excellent. अरे ये सब general knowledge बहुत है आप लोगों में. I am impressed. Excellent. So they do it intentionally. This is happening by chance. So when he lies down, he gets regurgitation. Because food comes up, this food also gets fermented. So he gets a bad odor. He gets halitosis or bad breath. And if it happens too many times, he can get aspiration. Okay, he can get aspiration pneumonitis. So how will the MCU come? A middle-aged man, little older than me also, complains of regurgitation. What is not seen in this disease? What is typically not seen? What is not seen typically? Which important symptom of esophageal disease is not same. Pain, don't say pain. Dysphagia. There is no dysphagia. Dysphagia is very uncommon. Okay. So my message for you is, if you see dysphagia, then it should not be Zenker's diverticulum. Should not be. There is no dysphagia. There is regurgitation. Okay. What will you do first? How will you investigate? Person comes with regurgitation. Doctor साहब जब मैं सोता हूँ खाना ऊपर चढ़ के आता है. What will you do? Excellent. See, now you're understanding. I don't have to teach you this. First investigation, upper GI endoscopy, UGI scopy. When I do UGI scopy, when I put the endoscope inside, I may see the diverticulum. Okay, I may see the opening. जरूरी नहीं है. If it's a very small opening, endoscope may miss it. I may see the opening of the diverticulum. So then, what is the investigation of choice? Which will 100% show me the diverticulum, how big it is, which side it is. Yeah, so there are two answers. My answer will be CT with oral contrast. Okay, that is my answer. CT with oral contrast. If this is not there in the option, next best answer will be barium swirl. Both are same. Okay, one and the same. But if both are there in the option, go for CT of the neck. Why not X-ray? X-ray will not show the diverticulum. It is soft tissue. X-ray will show calcium, stones, bones. It will not show diverticulum. I want to know diverticulum best seen on barium. Okay, this image is also there. So you can see this diverticulum here. To answer your question, this one over here. Okay, important to remember, diverticulum is posterior. It is not anterior. It's a posterolateral diverticulum. Okay, it is posterolateral. How do you treat it? Okay, so you saw all this. Ankit has given a full-fledged answer. Ankit, you have given two answers which are different. दोनों answer अलग है. Any patient with upper GI problem, first do endoscopy. On endoscopy, you may see the whole of the diverticulum. You may see it. But the investigation of choice to see how big the diverticulum is will be a CT with contrast. Okay, it will be CT with contrast. Alternatively, you can do barium swirl if CT is not there. All right. Now, how do you treat it? First, do I have to treat it? Is it necessary to treat it? Is it necessary to treat it? Is it pre-malignant? Okay, no, it's not pre-malignant. You will treat if symptomatic. Okay, only if it is symptomatic. Or if it is very large. अभी obvious है, अगर large है तो symptomatic होगा. Incidental ones you don't have to treat. Now, treat what? What do you do in the treatment? You can do two things. The simpler thing to do, which used to be done in the past, this is the diverticulum. Just excise it, cut it out. So open the neck, go inside, whichever side it is, and resect it. So old treatment was diverticulectomy, excision of the diverticulum. Many times when I do a diverticulectomy, so I have removed the diverticulum. Many times, just so that food does not get stuck, I also cut the muscle below it, this muscle, the muscle of the esophagus, so that that space opens up. Like how you did myotomy in achalasia, you do myotomy here in the esophagus, upper esophagus. That is called as cricopharyngeal myotomy, CP myotomy. तो क्या होगा, diverticulum भी चला गया and food will also not get stuck anymore. It will go easily. Diverticulum will not come back. But the treatment of choice today is this, where this device, you put a stapler inside the esophagus. This is the diverticulum. This is the wall of the diverticulum, the connecting part, the bridge. You staple this bridge. This is called as stapled diverticulopexy. Okay, so with a stapler, you are not excising the diverticulum. You are just dividing the wall of the diverticulum. That is called a stapled diverticulopexy. CP is cricopharyngeal. ये जो muscle है ना, this muscle is called cricopharyngeal muscle. Cricopharyngeus. You cut the cricopharyngeal muscle. So that is called a CP or cricopharyngeal myotomy. Alternate, if I don't have a stapler, अभी मेरे पास नहीं है stapler. Stapler costs 40-50,000 rupees. Instead of using a stapler, I can also cut this wall endoscopically. So if I don't have a stapler, I can just divide the wall with the help of endoscope. That is called as Dolman procedure. Okay, so in Dolman, you don't use stapler because I don't have stapler. If I have stapler, I will just do it. But if I don't have stapler, I can cut it with endoscope, scissors, cautery, and divide it. Right? That's it. Simple. What are the recurrence rates? Very less. Very low recurrence. So with surgery, the disease should not come. Right? So that is about Zenker's diverticulum. All important points you know now. Now coming to this disease, I'm sure some of you must be suffering from. क्लास में तो आपको ये पक्का सेंसेशन हो गई when you're studying. Definitely in medicine class which goes on till late night. So gastroesophageal reflux disease, common man will call it GERD, also called as acidity. So if someone says acidity, GERD. स्टेपल करने से क्या होगा? स्टेपल करने से डायवर्टिकुलम खुल जाएगा. Right now the diverticulum is like this. If I'm going to staple it, when I staple the wall, the diverticulum will become like this. That this area I staple. So now the diverticulum has opened up. So now when you will eat food, no, it will not get stuck. It will go down naturally. That's why staple. That's why no recurrence. I have converted it into a voice sign. मुझे नहीं पता. I have never heard of it. Maybe you have read it in some other source, not to be mentioned here. Anyway, so when you say acidity, what is really acidity? What is this that happens over here? If I smoke, if I have a lot of alcohol, which you guys are going to do tonight, I'm sure. 5 घंटे की क्लास के बाद when your brain is fried, of course you are going to do all that things which should not be done. You will realize why. So because of the gastric acid coming up, you get what is called as esophagitis. So GERD means there should be reflux of gastric acid. You know your stomach has acid, it will reflux into the esophagus. And your esophagus, poor little esophagus, is not supposed to handle the gastric acid. So the esophagus will start getting ulcers. That is called as esophagitis. आई बात समझ में? So when I say GERD, it is acid from the stomach going into the esophagus, causing ulcers in the esophagus, where you get those sensations. Right? That is GERD. So simple. So when you are going to smoke, why should I get GERD? What is the connection? Smoking or GERD का क्या संबंध? Or alcohol or stress? You know, right now you are going to have all the 3 risk factors: stress, smoking, spirits. Open LES. LES opens even when I have water. Collagen weakness. Trigger. Okay. Nee, metaplasia is much later. There is no incompetent LES. So there are some triggers which lead to an event which is called as TLOSR. TLOSR means transient lower esophageal sphincter relaxation. Transient lower esophageal sphincter relaxation. So your lower esophageal sphincter, what is its job? Its job is to keep it shut so that the acid doesn't come up. So if my stomach is over here and I told you I have a sphincter over here, this sphincter will protect the acid from coming up. So the acid that is formed in the stomach should not go up. That sphincter will prevent it from going. If the sphincter keeps opening, bar, like how if you keep passing comments and keep breaking my chain of thought, then the acid will come up. I will get angry. Same way, if the LES is not competent and if it keeps opening bar, acid will keep coming up, keep irritating. Focus on the word irritating, the esophageal mucosa. So whatever leads to increase in TLOSR is going to cause GRD. So what will increase TLOSR? Smoking, spirits or alcohol. That's why, whenever you are going to go for a weekend party, you first take a pandy. Why do you take pandy? For this. Certain foods. Any food which will cause TLOSR? Any food, any dietary trigger? Yeah, caffeine, very good, excellent. So I think you're speaking more out of experience than anything else. Caffeine, chai, coffee, chocolates, cocoa. Even chocolates give you that. They open acidity. Certain foods, oily food, spicy food, fine. But the thing is, if it happens once or twice, it's no big deal. If this happens again and again, it's a problem. Not everybody who drinks alcohol gets acidity. Not everybody who smokes gets acidity. Why? If smoking will open the sphincter, every time I smoke, I should get acidity, but everybody doesn't get it. Some of you are experienced, chained. Hota nahi hai. But someone like me, if I have one cigarette, problem. Stress also trigger, yes. ऐसा क्यों? No. It's not tolerance. Let's not put it like that. It's because this LES is not the main preventer of GRD. It has one of the small preventers. There are more factors which will prevent GRD. So, yes, this is important, but there are many more which will not let the acid come up. You know what they are? So, there are these mechanisms which prevent reflux. These mechanisms, apart from the LES, and all of them are important, in fact more important than LES. So my esophagus has three parts. It has a part in the neck, there is a part in the thorax, there is a part in the abdomen. यहाँ पे diaphragm होती है ना. So esophagus has three parts. What will prevent the acid from going up? This will come in MCQ. One of the mechanisms is LES. So when I smoke, LES opens. That's why it will become non-functional. But more than that, you see this muscle over here, diaphragm muscle. That diaphragm, it will also close the esophagus like this. It will pinch the esophagus, not let the acid come out. That is called pinch cork effect of diaphragm. Very important mechanism, pinch cork effect of diaphragm. Then between the esophagus and stomach, this area, you can see that the stomach, it's not coming straight with the esophagus. There is an angle. So the esophagus is like this, going straight here, and the stomach is going like this. You can see there is an angle between the esophagus and the stomach. That is called angle of His. That will also prevent reflux. Angle of His. This angle. It will prevent reflux. And the fourth mechanism, another important mechanism, is this part of the esophagus which is inside the abdomen. It is called intra-abdominal esophagus. Intra-abdominal esophagus. It will also prevent reflux. You will be like, sir, what are all these things? They are my other cofactors. This is the name. इंसान का नाम है जिसने वो एंगल बनाया. Pinch cork means diaphragm will close like this. It will be pinching. जो शैंपेन की बॉटल होती है, उसका जो ढक्कन होता है, the cork, when it is in the bottle, it's very tight. So the moment I take it out, whoops, this होती है. Now Dr. Ram will appreciate it. That is called pinch cork. Yeah, it is diaphragmatic crura, obviously. So, ये सारे mechanisms work together. All of them work together to prevent reflux. Okay, it's not just the LES, but also the diaphragm, also this angle. If the angle is not there, na, like if the esophagus and the stomach have no angle, ऐसे हो गया. If the angle is gone, then also I can get reflux. If my esophagus is very short, there is no abdominal esophagus. All the esophagus is in the thorax. I can get reflux. These are some mechanisms which prevent reflux. Why I'm telling you this is because this you will see in a disease called hiatus hernia. When I get hiatus hernia, all of these mechanisms are gone. Okay, we'll get to it. So these are the mechanisms which have to work. If these mechanisms don't work and I get these triggers, I will get reflux on a regular basis. So not every smoker gets reflux, not everybody who has spicy food will get reflux. It's when you also have some defect, some anatomical problem should be there. I hope you understood. This is not given in the books. The problem is this has a bearing on the treatment. But if you understood this, never in your life will you worry about reflux. Because this picture should be there, some of this is defect. Right? So acid will come up and start causing ulcers. Okay, I get ulcers. What's the big deal? ठीक है ना? हो जाएगी ulcer. What's the big deal? Pinch cork is different than intra-abdominal. Yeah, they are different. They are very different. So the main problem with reflux over time is one big problem is I can get something called as Barrett's esophagus. So if some of you irritate me a lot, you keep pinning me, keep interrupting, keep telling, sir, kya kar rahe ho? Sir, kya likh rahe ho? Sir, please repeat. Then what will happen is my mentality about you will change. That is called as Barrett's esophagus. It means the esophagus is so irritated, it has undergone a metaplasia. Metaplasia means normally esophagus is squamous. Now it has become columnar epithelium. It is a columnar metaplasia. And this metaplasia can become a cancer that is called adenocarcinoma. और नॉर्मली इसोफेगस में कौन सी कैंसर होती है? नॉर्मली इसोफेगस में कौन सी कैंसर होती है? SCC. Very good. Esophagus is SCC because it is squamous epithelium. Only when there is Barrett's, some squamous has become columnar, that can become adenocarcinoma. Okay, so adenocarcinoma is in the setting of Barrett's esophagus. Otherwise, it is squamous because lining of esophagus is squamous. So one problem is this. Second problem is as the ulcers will heal. So I get ulcers over here because of the reflux. As the ulcers will heal, the esophagus will start becoming fibrosed. It will start becoming contracted. So over time, the esophagus will start becoming shorter. And if the esophagus will become shorter, what will happen is, first the esophagus was this much. Then because of little inflammation, fibrosis, it became a little shorter. इतनी हो गई. So that it pulled the stomach up. As it became shorter, stomach started getting pulled higher. I got more inflammation. As more and more inflammation happened, now the esophagus is very short. It is not in the abdomen at all. It is only in the thorax. And it has pulled the stomach with it up like this. Khich, 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 khich. This is called as sliding hiatus hernia. Okay, this is called as sliding hiatus hernia. This was asked in FMG exam. In which type of hiatus hernia is the GE junction going to get pulled up? Sliding hiatus hernia. Okay, sliding hiatus hernia. Simple. Who gets sliding hiatus hernia? GERD. What else has happened in sliding hiatus hernia? One is, now there is no esophagus in the stomach. So, intra-abdominal esophagus is gone. Sari upar chale gayi. Angle of it is gone. Diaphragm will become stretched. So if I get hiatus hernia, I will get more reflux. I get more reflux, I get more shortening, more hiatus hernia. It becomes a vicious cycle. So first I get reflux, hiatus hernia, more reflux, more hiatus hernia. आई बात समझ में? It's a vicious cycle. This was asked in FMG, अभी वाला exam. These are the two main problems. ये sliding क्यों हुआ? Because the stomach is sliding into the thorax with the esophagus. It is sliding into the thorax. Stricture can happen, but it's very rare. It's a rare problem. There can be stricture, but that's very rare. The first two are bigger problems: sliding hiatus hernia and Barrett's esophagus. Anyway, how does the person present with GERD? Simple. He will say, I have heartburn or retrosternal burning pain. He can get epigastric pain. And in late stages, if the reflux is too much, he will say that the acid is going into my throat. It's not only in the esophagus. There is what is called as volume reflux. You can also call it regurgitation. So you can get volume reflux or you can get acid regurgitation. Acidity starts with chest pain, chest burning. But in the later stages, when there is too much of reflux, he will say acid is coming in my throat. That is a dangerous finding. If that has happened, that means disease has become very advanced. Okay, that means disease has become very advanced. So these are the two common, sour brush, absolutely right. Ketamine has given the correct term. So these are the two main symptomatic presentations. Starts with heartburn, acidity, ends with acid in the throat or volume reflux or regurgitation of acid. So these are two ways. What will you do next? What will you do next? Patient comes with acidity. Sir, clinically जो laryngopharyngeal reflux होते हैं, is it same as this? No. Those are atypical symptoms. Sometimes in GERD, you get some atypical symptoms. They are not seen in everybody. Like you can get cough, or you can get laryngitis. Voice changes, or you can get asthmatic attacks. This is all atypical. This is not seen in everybody. Right? Very good. So what will you do first? Person comes with acidity. First investigation. Lifestyle modification. Investigation, no. Please first do upper GI endoscopy. Always. You only need to do upper GI endoscopy. So whatever disease we have done so far, first test has been upper GI endoscopy. This is normal. Okay. This what you are seeing, white, pink, white. This is normal esophagus. Okay. Somewhere lower down, it will become stomach. थोड़ा नीचे. What you are seeing here, ये लाल लाल, all this red, भयानक सी चीजें. These are erosions. Or you can get ulcers. So you know it is esophagitis. Don't call this Barrett's esophagus. Huh? This is not Barrett's. I will show you how Barrett's looks. But it's not Barrett's esophagus. These are just ulcers or erosions. If I see this, okay, very good. This tells me he has GERD. Easy to diagnose, endoscopic diagnosis. But sometimes what happens? Sometimes person has symptoms, but his endoscopy is normal. होता है कभी कभी. Or person has atypical symptoms, like he has cough. Or you are going to plan a surgery for GERD. In these cases, you have to be sure that it is GERD. Only in these cases, you will do this test. That is called as 24-hour pH study. This books will say is the gold standard for GERD. It's a gold standard test. But please understand, gold standard does not mean I will do it in every way. Gold standard means it is the final deciding call, final person, final authority. जब मैं आपको पढ़ाऊंगा, I am like upper GI endoscopy. I will say, okay, this is important, this is not important. Zenkers is this, but gold standard final call will be Bailey and Law. Whatever is given in Bailey is the final authority. Similarly over here, if person says I get heartburn but endoscopy is normal, or he gets these abnormal symptoms, you're not sure, or he gets, you're planning surgery, you have to be sure that he is having GERD. Because please understand, if you do surgery but he does not get better, then what do? You have no proof. पेशेंट वेल से आपको पैसे बनाने थे इसलिए आपने ऑपरेशन कर दिया, मुझे तो एसिडिटी सच में थी नहीं, जैसे पहले थी अभी वैसी है. If you want to be sure, you will do 24-hour pH study because it is gold standard. But do I do it in every patient? No. Only when there is a doubt. So only if I teach something that you don't agree with, you will say, sir, I will check in Bailey. Same way over here. When you are not sure, when there is a doubt, when you are going for the surgery, you will go for 24-hour pH study. Okay. So symptoms basically are going to be burning in the chest or acid coming in the throat. This is what is seen usually. Some patients get some unusual symptoms. They are atypical. Some patients get. In these patients, you can do 24-hour pH study. If I'm going to do surgery, I will do 24-hour pH study because I have to be sure. भाई operation करूंगा वो 2 लाख रुपए भरेगा. What if the symptoms were never really of GERD? Because it's a very non-specific disease. If I told you acidity as a layman, you know what layman will say? पेट फूक जाता है. For them, that is acidity. Acid सर पे चढ़ा जाता है. That is acidity. Those kind of things also people perceive to be GERD, but it is not. So it's your job that before you do surgery, you have to be sure it is GERD. To be sure, you will do 24-hour pH study. What is this 24-hour pH study? How it is done? Yeah, Shobh is asking how it is done. How it is done? So it's very simple. A catheter is put from the nose for 24 hours. So a catheter is implanted. It's put from the nose like a Ryle's tube. It goes in the esophagus like this, and it records the pH in this area. And whatever pH it records, it comes on a recording device, on a transmitter. At the same time, the person is given a button. Whenever he gets any symptom, he presses the button. So there are two parts. One part is pH measurement in esophagus, actual pH. So यहाँ पे कितना pH है, यहाँ पे कितना pH है, यहाँ पे कितना pH है, over 24 hours gets recorded. Secondly, when does the person get symptoms? Any symptom that he feels is because of acidity, he will press a button. This is done for 24 hours. He has to bear the catheter. He has to bear the catheter. So it is going from his nose. So for one day he has to take chutti. He can't go to work with the catheter. Next day he goes, the catheter is removed and a chart like this is made. Now I told you how to read these charts because you would have never seen a chart like this. You see over here 11, 1900, 0300. This is all time. सुबह के 11 बजे, शाम के 7 बजे, सुबह के 3 बजे, सुबह के 11 बजे. And what do you see over here? What scale is over here? 0.51, 1.5, 7.5, 8, 8.5. What? See this word over here. pH. So it is measuring pH over time. Okay. Measuring pH over time. So that is why this is a 24-hour pH study. देखो कॉमन सेंस से करोगे ना तो हो जाएगा. कॉमन सेंस ही है ये सब चीजों में. Now what do you need to see here is all these red lines that you see, they are the actual pH. So this pH are these red lines. Like you can see at this time in the day, pH was very low. Again, at this time in the day, late evening, pH was very low. Early morning, pH was very low. So it has seen how the pH was. These white lines that you see are when the patient pressed the button, when he got the symptoms. So what you can see are two things. One is actual pH, second is patient symptoms, and you try to match. Did he get symptoms at the same time when the pH fell? If it's matching, that means yes, it is GERD. So you see over here, he's gotten the symptom here, pH is low. He's gotten the symptoms here, pH is low. Symptoms and pH are happening at the same time. This is given by a score which is called the Meester score. So what is the score telling you? It is telling me, do the symptoms match the fall in a pH? Means actual acidity. If it is more than 14.7, it is significant. आगे बात समझ में? अगर मेरे पास ये proof है ना, that means he is having symptoms because of acidity and not because of anything. This is 24-hour pH study. Someone was asking, can he eat with the catheter? It's difficult, but he can eat it. So instead of putting a catheter, there is a new technology. Someone wrote in the chat that they put a capsule in the lower esophagus. That is called Bravo capsule. So catheter के बदले capsule लगा देते हैं, and that capsule automatically dissolves and it gets passed in your stools. And this will give you pH not for 24 hours. It will give you pH for 48 to 72 hours. So even more duration. And patient is comfortable. No problem. He's living happily. Yeah, but to put the capsule, you have to do endoscopy. अपने आप capsule वहाँ नहीं जाएगी. वो solo वाली capsule नहीं. It has to be implanted. Okay, fine. So this is how you come to the diagnosis. Last part is treatment. How are you going to treat GERD? How are you going to treat it? Acidity, ulcers, no complication yet. So please remember, very important, this is not a surgical disease. The treatment of choice is medical. Okay, treatment of choice is medical. You will give PPI for 4 to 8 weeks. Okay, for temporary relief, this is fine. Then when will you do surgery? Role of surgery. Because not everybody, आपको acidity होगी, मैं surgery नहीं कर दूंगा. 5H3 hashtag. I don't know what that means. Vishnu Vardhan. What is 5H3 hashtag? Okay, it's very simple. I will do surgery if the symptoms are very severe, like volume reflux, regurgitation. ऐसे बड़े बड़े symptom हुए ना, then I am not going to just do PPI. Volume reflux, dangerous symptom, or if he has complications like Barrett's esophagus, hiatus hernia. उस scenario में I will do surgery. And what surgery do? I do this surgery. They are called as anti-reflux surgeries. Common name, fundoplication. The most common one that you see in the image, this is called as floppy Nissen fundoplication. Fundo means fundus of the stomach. Plication means to tie it around. So what you do is, this is the esophagus, this is the fundus of the stomach. The fundus is wrapped around the esophagus like this. You wrap it around, खींच and press. So it will make the lower esophagus little tight. That is called as floppy Nissen. What you see here, fundus has gotten wrapped full 360 degrees, complete. That is floppy Nissen. It's a 360 degree wrap. What is the problem? Does it lead to anemia? No. Why should it lead to anemia? Dysphagia nahi hoga. Yeah, absolutely right. So patient will say, doctor, when I came, I had acidity. Now acidity has gone, but food is not going down. Because if the wrap is very tight, acid तो नहीं आएगा, लेकिन खाना भी नहीं उतरेगा. So you have kind of created an achalasia, kind of. That is called as, so the most common complication that you can get is short-term dysphagia. Okay, this is the most common complication, short-term dysphagia. Other problem you can get is called as gas bloat. वो डकार नहीं मार सकेगा. To prevent these complications, nowadays what we do is we don't do 360-degree wrap, we do little less wrap. So nowadays what is done is a partial wrap. That is called a partial toupet, T-O-U-P-E-T, toupet fundoplication, in which you do a 270-degree posterior wrap. Okay, you do a 270-degree posterior wrap, simple. So पूरा नहीं wrap करो, थोड़ी जगह छोड़ दो, make it a little loose. That is called toupet. So the risk of dysphagia is very less. And someone was asking, sir, please discuss FMG questions. This question was there, abhi wale FMG. During endoscopy, man is found to have scomocolumnar junction located more proximally. Which of the following conditions is likely to be responsible? Easy question. So, if the scomocolumnar junction or GE junction has gone more proximal, he's having a sliding hernia. In achalasia, it is normal. What are these hernias? Rolling paraesophageal hernias. They are a little different. Okay, they are not related to GERD. Sliding hernia is seen in patients with GERD. Rolling hernia is not linked to GERD. There is no connection. So what happens in rolling hernia or paraesophageal hernia? So your hiatus is a little big. So what will happen? Esophagus is in the normal place, but the stomach goes up from the side. So this is my esophagus. This gap is very big between the diaphragm and the esophagus. So the stomach goes up like this into the chest. That is why paraesophageal, next to the esophagus. It has rolled. It has not gotten slid or pulled. It has just gone by itself. This is called rolling or paraesophageal hernia. Okay, these are the two common types of hiatus hernias. Sliding type, rolling type. Will the Bravo capsule, should the patient be admitted? No, he does not need to be admitted. Rolling or paraesophageal hernias have no connection to GERD. They are seen in people who are elderly, who have muscle weakness. Muscle weak होने से diaphragm थोड़ा फैल जाता. So when I say hiatus hernia, there are 4 types that you need to know. The first type is the sliding type, which is the most common, which is seen in patients with GERD, where the GE junction gets pulled down because of the esophageal shortening. The second type is the rolling type. Here there is no GERD. This one, where only the stomach has gone up. So GE junction is normal. And the third type is a combination. This is seen sometimes. This is called a mixed type, where there is GERD, there is pulled up GE junction, and stomach has gone from the side. Both, a combination of this and this. दोनों का मिक्सचर कभी कभी होता है. आगे बात समझ में? Sliding thorax, rolling abdomen. No, that's not how it is. Both are going into the thorax only. Barrett's not mandatory in GERD. करेंगे ना Barrett's? घबरा क्यों रहे हो? All in good time, सब करेंगे. Barrett's करे तो सही, फिर आपको सब समझ में आ जाएगा. Now coming to Barrett's esophagus. Yeah, images से थोड़ा दिखवा दो. Mixed बताना फिर से एक बार. Sliding type looks like this. This is sliding. G junction has gone in the thorax. This is a rolling type. Only the stomach has gone into the thorax. There can be a combination of the two. That is the mixed type, where G junction has also gone into the thorax and stomach has also come into the thorax like this. But obviously, it's not so common. In the fourth type, other organs go into the thorax. In the fourth type, other organs, not the stomach, enter into the thorax. आ गई बात समझ में? In one word, if I ask you what is the treatment of type 1, type 2, type 3, type 4 hiatus hernias? Paraphysiophageal and rolling are the same. Yeah, they are the same. In one word, how do you treat the 4 types of hiatus hernias? Fundoplication. Okay, the answer is what Mohammed Faisal said, surgery. Okay, surgery is the treatment. All hernias in general surgery have to be treated by surgery. Remember this forever and ever. There is no other treatment for a hernia. Hiatus hernia, inguinal hernia, umbilical hernia, whatever hernia. You are going to do surgery. What surgery? It's okay. Some of you are saying fundoplication. Fundoplication is not necessary. Yeah? But the answer is going to be surgery. Rolling and paraesophageal are the same. They are synonymous. Okay, यहाँ लिख देता हूँ rolling और paraesophageal, ताकि आपकी आत्मा को शांति मिले. वरना कल तक आप मुझे ये पूछोगे rolling paraesophageal, right? So that is about one complication. Other complication is Barrett's esophagus. I already told you what this is. This is going to be seen as a complication or a sequelae of GERD. Basically, someone who has a long-standing GERD. So I hope this answers your question. Is Barrett's necessary? It's not necessary. If I have early GERD, I will not get Barrett's. Barrett's will be seen if I have GERD for many years, over a period of time. So see, if you interrupt me once or twice, I will not get very angry. I will get a little pissed off. But every day, every few hours, if you are going to interrupt for all the days, then of course, yeah, sequelae matlab complication. So over a period of time, Barrett's esophagus will develop. Not एक बारी में नहीं हो. Okay, एक बारी में नहीं हो. So what is Barrett's esophagus? It is a columnar metaplasia. Okay, it is a columnar metaplasia of lower esophagus. Okay, of lower esophagus. Means what? I told you that the esophagus and the stomach have a junction over here. The part above is esophagus. The part below is stomach. Esophagus, squamous. Stomach, columnar. है ना? Stomach, columnar. Sometimes what will happen because of acidity, some esophagus gets stomach epithelium or intestinal epithelium. That is Barrett's. How much of epithelium should be seen to call it as Barrett's? What should be the length of the Barrett's? Very good. It should be at least 1 centimeter in length. So the length of Barrett's should be more than 1 centimeter. कम से कम 1 centimeter जितना epithelium should be intestinal or columnar in the esophagus. Then I will say yes, he has Barrett's. आगे बात समझ लो. This is the textbook answer. How will the person present with Barrett's and why is it a big deal? Clinical features of Barrett's. How do I know he has Barrett's? What are the clinical features of Barrett's? Ulcer. No, ulcer is not a feature. He will present with GERD. For a long time. Usually it will be for a long time. I have written here long time. Don't ask long duration, short duration. I have written long time. So he will say, since many days I am having acidity. You will do endoscopy. What will you see on endoscopy? Is this. So the investigation is going to be endoscopy. Obviously, because you thought he had GERD. When I do endoscopy, I see this. What you see here are these projections. These projections are what are called as tongue-like projections. So they are tongue-like projections of intestinal or stomach epithelium. This white part that you are seeing, this is all esophageal mucosa. All this red part which is gone up as a projecting, this is going to be Barrett's esophagus. But how do I confirm it is Barrett's? How do I confirm that it is Barrett's? Biopsy, obviously. So I need to know that it is biopsy. Should he definitely have history of GERD? Most patients will have, unless he's ignoring it. See, GERD is very non-specific history. You and me may be having it, but we just don't care about it. So it's not necessary, but usually it will be there. So what I'm going to do is I will take a biopsy. And what will the biopsy show? The biopsy will show mucus secreting goblet cells. That is the hallmark of Barrett's. Mucus secreting goblet cells. That means, chalo, he has Barrett's. 100% he has Barrett's. So the biopsy should show mucus secreting goblet cells, and this length of Barrett's should be at least 1 centimeter. Why am I so worried about Barrett's? You said there is adenocarcinoma risk. What is the risk of adenocarcinoma? I posted this question on my Telegram also. Yeah. What is the risk of adenocarcinoma in Barrett's? If there is no dysplasia, if there is low grade dysplasia, if there is high grade dysplasia, risk of adenocarcinoma. If there is no dysplasia, the risk is only 0.2 to 0.5%. You need to know this number, 0.2 to 0.5% per year. If there is low grade dysplasia, it is 0.7% per year. If there is high grade dysplasia, it is 7% per year. So basically, if there is Barrett's, he has some chance of cancer, depending on did the biopsy show dysplasia. Okay, depending if the biopsy showed dysplasia. What is dysplasia? How is it different from metaplasia? Metaplasia, dysplasia, how are they different? Are they even different? No dysplasia, low grade dysplasia. Very good, excellent, 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 brilliant. Metaplasia can become normal. Dysplasia means permanent. So if you are thoda irritating me, I will get irritated for some time, but tomorrow when I will come, I'll be okay. But if you keep irritating me, then my mentality about you will change. That is dysplasia. This happens in your class also. When you go for certain teachers' classes, they say things which offend you. It happens. It's happened to me also. If they are offensive beyond a certain point, your mentality about that teacher will change. कि नहीं यार ये इससे मेरे को पढ़ना ही नहीं. He is ridiculing us, or he is being very unprofessional, or whatever. So if there is dysplasia, then the mentality changes. That means it will never become a normal epithelium by itself. Right? So, yeah, absolutely right. It is kind of physiological. Metaplasia can become normal. Dysplasia can never become normal. So if there is someone against whom you are very hurt, you will never feel the same. It's seen in your friendships also. दोस्ती में भी होती है, इसने कर दिया. If you have seen दिल चाहता है, have you seen that movie? I don't know, it's way beyond your generation. Yes, somehow I feel you have not seen it. I was a child. Exam के बाद. In that movie, the three friends keep troubling each other all the time. So sometimes they are happy, sometimes they are sad. Metaplasia. But Shed and Ladkin is different. But at one time where Amir Khan gets slapped by Akshay Khanna, then the friendship is torn apart. No, not when he throws phone. पता है तुम लोग कौन सी पिक्चर की बात कर रहे हो? दिल चाहता है. So when Akshay Khanna slaps him, that's when the friendship breaks. So that is a period of displeasure. Okay. So even if, yeah, very good. Brijman has given a good example. Even if there is no more acidity, dysplesia will remain. आप लोग ना दिल चाहता है जिंदगी ना मिलेगी दोबारा को मिक्स मत करो, ओके, ऐसा मत करना, उसमें ऐसा कुछ नहीं होता। हाँ, थैंक यू श्री समा। आई वॉज वंडरिंग कौन सी पिक्चर में किसको लेके आ रहे हैं लोग। सो यू गॉट द पॉइंट। हाउ दे बिकम फ्रेंड्स अगेन, उसका आंसर मिलेगा रे, डोंट वरी, आंसर भी दूंगा उसका, दे हाउ दे बिकम फ्रेंड्स अगेन। एनीवेज, टू कंफर्म बैरेट्स there is a diagnostic protocol which is called Seattle protocol. Problem क्या है? If I take a biopsy here and it shows no dysplasia, does that mean बाकी सब जगह पे भी dysplasia नहीं? There is no guarantee. So what I have to do is, every time I take biopsy, I don't take biopsy only from here. I take biopsy from the 4 quadrants. 1, 2, 3, 4. Then I go a little higher, 2 centimeters higher. Take 4 more biopsies. Go higher. Take 4 more biopsies. And I keep doing this till the upper limit of Barrett's. This is called Seattle Diagnostic Protocol, which means you have to take 4 quadrant biopsies at 2 centimeter intervals. आई बात समझ में? 4 quadrant biopsies at 2 centimeter intervals. This is the diagnostic protocol. Only if all the biopsies show that there is no dysplasia, then you will say no dysplasia. If somewhere you see dysplasia, then it is dysplastic Barrett's. Okay, are we clear? So 2 centimeters upper in all the 4 quadrants. Anyway, how do you treat it? How did they become friends again? Now the question will get answered. So very good. So if there is no dysplasia, then all you have to do is just prevent. तो दो दोस्तों में थोड़ी ज्यादा अनबन हो गई, then for some time just be quiet, don't pull each other's legs. So if there is no dysplasia, treat GERD, but you have to do endoscopic surveillance, वरना बात बिगड़ ना जाए. So every 3 years to 5 years, every 3 to 5 years, to endoscopic surveillance means every few years they have to go to Goa to renew their ties. You know they go to Goa. तुम लोग पिक्चर देखते नहीं हो ना, तो उनको हर 2-3 साल गोवा जाना पड़ता, so that their ties are maintained. Same way, surveillance has to be there, so that अभी तो नहीं है dysplasia, बाद में dysplasia आना चाहिए. If there is a low grade dysplasia, अब मुद्दे की बात, dysplasia will not go away. So just surveillance, just treating GERD is not going to be enough. If there is a dysplasia, it has to be removed. Means you are going to do radio frequency ablation of the Barrett's, or you will resect the Barrett's. That is called as endoscopic mucosal resection. If there is dysplasia, it has to be removed. You know who was the dysplasia in Dil Chahta Hai, and how did she get removed? Same thing over here. The dysplastic epithelium has to be removed. Otherwise, cancer can happen. So you do endoscopic mucosal resection, and then you treat GERD, and you do surveillance. If the dysplasia is very high grade, means too much problem, very high risk of cancer, this will require a detailed discussion, multidisciplinary team discussion, where more people will have to get involved to decide what the problem is, how big the problem is, and you will have to treat it like a cancer. Okay, you have to treat it like a cancer. आई बात समझ में? This is about MDT, multidisciplinary team. Because this dysplasia can become cancer anytime. There is a 7% risk of it becoming cancer. Simple. For MCQ, these are going to be your answers. Investigation of choice will be endoscopy with biopsy. बिना biopsy कैसे बताओगे Barrett's है? Biopsy तो करनी पड़ेगी. Goes without saying. So of course you have to do biopsy. The treatment depends on whether there is dysplasia or not. If there is no dysplasia, then just do surveillance. If there is dysplasia, that has to be removed. Just remember this. Dysplasia, high risk of cancer. It has to be removed. If the dysplasia is a very high grade, you have to treat it like a cancer. Means you have to do esophagectomy. बताएंगे ना, अभी कैंसर करेंगे, आपको समझ में आ जाएगा, राइट. थर्ड पॉइंट प्लीज, multidisciplinary team discussion means talk to the pathologist, talk to the surgeon, talk to the GI physician, and decide what is to be done. You will have to treat it like a cancer of the esophagus. Last thing, C esophagus. One thumb rule: all GI cancers are bad cancers. Okay, all GI cancers are bad cancers. Bad because why? Why are they bad? What is the 5-year survival in C esophagus? How many people will survive with C esophagus at 5 years? Very good. Less than 10%. Okay. Less than 10% people will survive with C esophagus. Why? क्या बड़ी बात है? It's because, no, why metastasis? It's because the tumor presents very late. By the time the person will be diagnosed, he will have metastasis. So it is a late presenting tumor. Why? He will have symptoms which are very non-specific. He will have little weight loss, dysphagia. He will think acidity. कुछ बड़ी बात नहीं. By the time he gets diagnosed, tumor is very big and it has spread everywhere. This holds good for all GI cancers. So esophagus, stomach, colon, rectum, even hepatobiliary, bad cancers. Not easy to treat. What are the pre-malignant conditions for C esophagus? For squamous cell carcinoma, for adenocarcinoma, for MCQ. Yeah. For squamous cell, for adenocarcinoma. Can esophagus transplant be done? You don't need to do transplant. You can put colon in place of the esophagus. So for squamous cell carcinoma, important, I told you, one was achalasia. I hope you are not saying achalasia cardia. Then corrosive injury, means you had some poison, acid poisoning, alkali poisoning, corrosive injury. Or if you had esophageal webs. Webs are also pre-malignant. Okay, they are seen in upper esophagus. Any risk factor for adenocarcinoma? Zenker is not pre-malignant. Very good for adenocarcinoma. Most important is Barrett's. This will come in MCQ. Huh? They will ask you, all of these lead to squamous cell carcinoma except answer is Barrett's. Barrett's, adenocarcinoma. ठीक है? तो ये हो गए आपके even obesity. You know what I do? Anybody knows my profession? What surgeries do I do? Anybody knows क्या? Caustic corrosive are the same here. Yeah, bariatric surgery. Human knee. At least I'm not a vet. If I were a vet, I would not be teaching you. Bariatric surgery is done in people with obesity. A lot of my patients have tumors of the upper GI tract, esophageal, stomach cancers. They are at a higher risk because of obesity. No, I'm not one of the best surgeons. Anyways, what happens in C esophagus? Where does it happen commonly, and how does it present? And what's the big deal about C esophagus? So if they ask you most common site, it will be middle esophagus and it will be squamous cell carcinoma. But if they ask you most common site in the Western world, in Western world, it will be lower esophagus and it will be adenocarcinoma. Anybody can tell why? Why adenocarcinoma in Western world? Why not in India? No, smoked food nahi hai. Smoked food will cause stomach cancer. It's because there is more obesity, more smoking, leading to more GERD. More GERD, more adenocarcinoma. Okay, it's because of smoking, obesity, GERD. So that's why in the Western world, India में अभी बढ़ रहा है. अभी तक इतना नहीं था. High lifestyle, yeah, high flying lifestyle. I think अभी आप लोग भी सब करते ही होंगे. Spice usage in India. Anyways, so how will a person with C esophagus present? Clinical features. How will he present? Cancer now will be the easiest thing for you in the whole of surgery once you learn it from me. Kabhi problem nahi. Pawan Kumar is having burgers every day. Yeah. How will the person present? It will be an elderly smoker male. So young non-smoker female, achalasia. Elderly smoker male means 60-70 year old, मेरे से ज़्यादा elderly. He will present with progressive dysphagia, painless progressive dysphagia. This will be initially more to solids. Okay, solids more than liquids. Initially, a liquid है LIQUID liquid. So he will have dysphagia. He may have regurgitation. He may have weight loss. ऐसा कुछ कहीं और भी देखा था क्या? Dysphagia, regurgitation, weight loss. You saw it somewhere else also. Where did you see this? Dysphagia, regurgitation, weight loss. It was the triad of achalasia, isn't it? So you are getting very similar features in cancer like you got in achalasia. That is why it is also sometimes called as pseudo-achalasia. Pseudo-achalasia, it means symptoms of achalasia in patient with cancer. That is pseudo-achalasia. कभी-कभी होता है. But all these symptoms come very late. He can have features of metastasis. ठीक है? Patient comes with dysphagia, regurgitation, weight loss. What do you do first? First investigation. सबसे पहले क्या करोगे? अब मजा आएगा. Obviously, you need to do only one thing. You want to do upper GI endoscopy with biopsy. Here you will have to do biopsy to tell that it is adenocarcinoma or squamous cell carcinoma, SCC or adenocarcinoma. ठीक है, पता चल गया कैंसर है, फिर क्या करोगे? सर्जरी सीधा? Staging. Please remember, in any cancer, after diagnosis, you want to know the stage. Stage means you want to know the extent of metastasis. You want to know how much it is spread locally. You want to know, is there any distant metastasis? Because esophagus के पास में there is trachea, there is stomach, there are nerves, there are lymph nodes. You want to see has the cancer spread anywhere, because you can't operate till you know how much it has spread. For local staging, you do a test which is a type of ultrasound. It is called EUS, endoscopic ultrasound. This will tell you tumor के आसपास how deep it has gone. Has it stuck into aorta? Has it stuck into trachea? Whatever is around, has it spread into that? Because if it is tumor which has gone into aorta, I cannot do surgery. Aorta थोड़ी ना निकालूंगा. Esophagus तो निकाल दूंगा, aorta थोड़ी निकालूंगा. So esophagus, aorta, all these areas I have to look. For distant metastasis, lung mets, liver mets, bone mets, what do I do? How do I come to know distant metastasis? कहाँ कहाँ फैला हुआ है? Very good. I will do PET scan. Okay. In all your GI cancers, esophagus, stomach, small bowel, colon, rectum, you are going to do this. Okay. सारे के सारे cancers. After doing this, you will get the TNM staging. Okay. Have a look at this slide. I will give you a little break now for 10 minutes. When I come back, we will do the treatment and go to stomach. Okay. So I have a good look at this side. And 10 minutes now I will come back. EUS is endoscopic ultrasound. Endoscopic ultrasound. It's a special type of ultrasound. As simple as that. Okay? Remember, achalasia, most common motility disorder, which has two important findings: very tight LES and weak peristalsis. Investigation of choice, esophageal manometry. Treatment of choice, Heller's myotomy, except type 3 achalasia. Is vomiting a symptom of GERD? It's not really vomiting, it's reflux which the person feels as vomit. The thing is, vomiting, when you do, your stomach contracts and it goes at a distance. Vomiting is projectile. इसमें वो नहीं होता. It just comes in your mouth in the late stages, not in the early stage. Okay? No, it's not a risk factor. They are unrelated. Anyway, so we were doing C esophagus. You did the endoscopy with biopsy. Now you know there is a tumor in the middle esophagus. It is a squamous cell carcinoma. You did the EUS, you did the PET scan, you got the TNM stage. Now when you do TNM stage, it has three parts. T, which stands for tumor depth. In the GIT, you have four layers. You know, if you go from out to in, there are four layers. You have the mucosa, then you have the submucosa, which has the blood vessels, then you have the muscularis, and सबसे बाहर is the serosa. The outermost layer is the serosa. So normally, all tumors in GIT, most of the tumors, I won't say all tumors, they arise from the mucosa. That's why adenocarcinoma, squamous cell carcinoma, they are coming from these cells, the epithelial cells. So tumor will always start in the mucosa, barring a few exceptions. So the tumor will start from the epithelium, and as it will grow, it will go into the submucosa, then into the muscularis, then into the serosa, and then into adjacent organs. That's how the tumor will go deeper and deeper and deeper. Okay, that is what is the TNM stage, the T part. So the T part tells you how deep has the tumor gone. And it's very easy to remember because the layers are mucosa, submucosa, muscularis, serosa. So T1A is going to be tumor only in mucosa. T1B, mucosa and submucosa. T2, muscularis. This is important because if the tumor has gone into muscularis, it can spread to blood vessels, it can spread to lymphatics. So once it has gone into the muscularis, it can also go into the blood vessels and into the lymphatics. T3 is tumor invading adventitia. Please understand, esophagus, there is no serosa. There is only adventitia. So T3 is tumor gone up to the adventitia. And T4 has two things, T4A, T4B, into adjacent organs. Like near the esophagus, you have the trachea, just in front of the esophagus. If the tumor goes into trachea, or if the tumor goes into stomach, so T4A, tumor has gone into resectable structures, like stomach, or pleura, because pleura can be removed. T4B means tumor has gone into unresectable structures like trachea, aorta, heart, and so on and so forth. This is the T stage. Okay, this is the T stage. Laiba, you can increase your volume. I am really close and I was listening to the recording myself. So the audio problem is not on my end. Please be very certain about it. Right. So the T stage tells me how deep the tumor has gone. Then you have N stage. N is not that important. And you have M stage, in which you have M0, M1. M1 means there is distant metastasis. Okay, there is distant metastasis. Obviously, what treatment I am going to do is dependent on the TNM stage. So first thing is, when you think about cancer, you need to know the TNM stage. Okay, you need to know the TNM stage. After all this is done, yeah, we forgot this image. Anybody can explain what this image is? This used to be done in the past, not done anymore. So this is a barium swallow. Like you saw in barium swallow in achalasia, here you have barium swallow. But why is it not achalasia? What is it that is telling you it is cancer? It's very simple. You see some dilated esophagus here, but see how it is narrowing all of a sudden. It's not narrowing like that, like you saw in achalasia. It's not narrowing like this. It is narrowing very suddenly. So this is the proximal esophagus, and suddenly it has become narrow. So on barium swallow, what you are going to see is an abrupt narrowing. Okay, it is going to be an abrupt narrowing, and this part where the tumor is, you will see filling defects. So what you have are abrupt narrowing, filling defects. This appearance can be called as rat tail, but I would not use the word rat tail. A better word is shouldering. It appears like your shoulders. So broad shoulder suddenly transitioning into a narrow neck, that is called shouldering sign. This is what will tell you it is carcinoma and it is not achalasia. Are you someone? Yeah, you can get apple core also. Absolutely right. This appearance that you see, this is apple core appearance, where proximal part is dilated and there is some distal part which is also dilated. And the Bichka part is the narrow part. That is apple core. Proximal distal dilation with a narrowing in between. Absolutely right. In barium swallow, I'm looking at esophagus. In barium meal, I'm looking at stomach. But the main difference is when I do barium swallow, what I drink is not barium liquid. It's a barium paste because I want it to go down slowly. If it goes down very fast, by the time the X-ray is taken, barium will be in the stomach. So when I do barium swallow, I don't drink barium liquid. I take a barium paste. It's thick. For barium meal, I can drink the liquid. Okay, I hope that answers your question. Legitimate question. Both images are cancer only. None of them are achalasia. Both are cancer. Because you see that the narrowing is becoming very sudden. Okay, sudden narrowing gonna be cancer. Achalasia was this. Very smooth narrowing. This one, see? Smooth narrowing. Here also you saw it. Smooth narrowing. So don't make ask this enough number of times, but I don't think they will continue to ask it anymore. इसका time गया. Barium swallow वगैरह का. अब नहीं पूछेंगे. They are past it. Last part in C. esophagus is how do you treat C. esophagus? Rather, how do you treat any cancer? That's the most important part. कोई cancer है तो इलाज कैसे करोगे? Which you as a doctor should know. No, this is only for esophagus. As we'll do more cancers, you will see. करेंगे ना सारे cancers करेंगे. One step at a time. The principle is the same for all GI cancers. So treatment depends on stage. Is the tumor early? Early means not spread anywhere. If the tumor is early, then the treatment is going to be surgery. And in some cases, you will give chemotherapy. When I give chemotherapy after surgery, what is it called? Chemotherapy after surgery, what is that called? Very good. Shashwat has given good terminology. It is called adjuvant. Okay. Adjuvant means post-surgery. Chemotherapy after surgery is called adjuvant chemotherapy. If the tumor is advanced means it is stuck to something in the vicinity, like tumor is stuck to trachea or stuck to the pleura, and I can't do surgery. In that case, I want to make the tumor a little smaller. I want to shrink it. To shrink it, what I'm going to do is first I will give chemotherapy so that it becomes downstaged. This is called as neoadjuvant chemotherapy. This is called neoadjuvant. Neoadjuvant means before surgery. After chemotherapy, I will do surgery. Okay, so you got the difference. This holds good for every cancer. Whenever you study cancer, the first question you are going to ask, is it early, advanced, metastatic? If it is early, surgery followed by chemo. If it is advanced, you can't start with surgery. So you have to start with chemo. Make it smaller. Once it becomes downstage, then you do surgery. Okay, ekdam clear? Metastatic means it has spread. If it has spread, you are not going to do any surgery usually. You will just do palliation. Okay, you will just do palliation. Palliation means just improve the quality of life. No surgery. If he is not able to eat, you can put a stent in the esophagus. Just so that he is able to eat. It's one of the ways to palliate. Okay, this I will speak in every cancer that we are going to study. Early, advanced, metastatic. Yeah, आराम भरोसे आज के ज़माने. Now come to the exact surgery what you are going to do in esophagus. Little bit I will tell you what comes in the exams. कि क्या करना है surgery में. Surgery में you need to do two things in esophagus. One is How do you approach the esophagus? Or what are the accesses? Because the problem is esophagus is in the neck, it's in the chest and in the abdomen. If I want to remove full esophagus, I cannot only open the chest. I have to open different areas. So I have to decide where all will I cut to remove the esophagus. So the approach should be, there are two that you need to know. One is, someone wrote in the chat very correctly, Ivor Lewis. सिर्फ दो ही याद रखो. Ivor Lewis, also called as double approach. Double means you have to take two incisions. So if this is the neck and this is the chest, these are the ribs, this is the abdomen. To remove esophagus by double approach, I will take two incisions. One incision will be on the abdomen, one incision will be here on the right thorax, because the esophagus will be somewhere here. ऐसे होती है, neck, then chest, like this. Then it goes into the abdomen, becomes the stomach. So if I want to remove only distal half esophagus, I can do Ivor Lewis or double approach, where I will do laparotomy, means abdomen is going to be open, and I will do right thoracotomy. Okay, right thoracotomy. आई बात समझ में? So two incisions, one in the upper abdomen, laparotomy, one in the right chest, because in the chest it's easier to go from the right, because heart आती है ना लेफ्ट में. आप लोगों की है कि नहीं मुझे पता नहीं, esophagus के आगे तो लेफ्ट में heart होती है, easier to go from the right. The second thing is, if I want to remove full esophagus, full means all the way till the neck, then I also need to take an incision on the neck. That is called as McKeown's approach or triple approach. Triple means you do these two. You do laparotomy, means Ivor Lewis part, so you are going to do. You do right thoracotomy, but you also take a left neck incision. Okay, the incision is on the left side because esophagus in the neck is on the left side. So third incision will be here, left neck incision. If you have understood this part, no, 90% of esophageal surgeries you have understood. 90%. Students are so confused when I tell them this. Before I tell them this, there should be clarity. ये दो ही आने चाहिए. These are the two most important and commonly done. If I want to remove only lower half of esophagus, double approach, right chest, abdomen. So in that I can remove distal esophagus, means this much esophagus I can remove by Ivor Lewis, this much. But if I want to remove full esophagus all the way till the neck, I will also need to cut in the neck to reach that esophagus. So that incision will get me access to full esophagus. That is triple approach. Abdomen, right thorax, left neck. Because if I want to cut the esophagus in the neck, I have to go into the neck. No, how else will I remove it? है बात समझ में? ये दो ही याद रखो. There are more incisions, but don't worry about them. These two are the ones which are commonly done. These two are the ones which will come in your exam and which you should try to remember. Others are not that important. There are more, but not that important. Now, once I have opened all this, how much do I resect in the esophagus? So I will resect esophagus lymph nodes. I need a margin in esophageal cancer. Anybody knows how much margin? Cancer may I need to remove normal esophagus also. How much margin? Margin should be at least 10 centimeters proximal. Remember only this, 10 centimeter proximal. Okay, which means if the tumor is in the lower esophagus, if it is over here, for example, this is the esophagus, and if the tumor is over here somewhere, I need to go 10 centimeters upper, kam se kam, and cut. If it's in the middle esophagus, 10 centimeters up till the neck. Okay, resection margin is going to be 10 centimeters. After I have removed the esophagus, I will have to do anastomosis. If esophagus is gone, what will I bring in its place? I will eat. इतना बड़ा जो gap है of the missing esophagus, how will I fill the gap? Someone was asking esophageal transplant. How do I fill the gap? No, not artificial. No. I pull the stomach up. Anastomosis, I do a pull up of the stomach. So whatever stomach is left, I make it into a tube and I pull it up. So whatever esophagus is left, I join the stomach by pulling it up. So now the stomach will come in the chest or maybe in the neck, depending on how much esophagus I remove. So I have to do a gastric pull up. This is the esophageal replacement. Okay, so I have not done any transplant. I have done a substitute. So now there is no esophagus, stomach is there, make it into a tube and pull it up. Sliding effect will be there. It's much worse. It's much worse. These patients are miserable. It will cause many problems. But Rajesh Nishant, you have no choice. What else can you do? Not GERD, much worse. Now stomach is in the chest. Acid will come into his mouth straight away. So GERD to choti baat hai, it's much worse. But you have no choice. Stomach has to be pulled up. Okay. There are alternates, but stomach is most preferred. Okay, colon is not very preferred. It's not very easy to bring the colon. You can't bring up the stomach, then you pull up the colon. Sanu was asking distal margin. Distal margin depends on the location of the tumor. Distal margin, see, this will make you confused. It's going to be 5 to 10 centimeters distally. Okay, but don't worry about it. Remember proximal margin. Proximal is more important because distal there is no problem. I can go distally as much as I want. Proximal is important. Okay, remember the proximal margin, not the distal margin. Okay? So this is how you are going to manage CA esophagus. These are the surgeries that you need to know. Know these two approaches. One is going to be double approach, where you take one cut on the abdomen, one cut on the right thorax, Ivor Lewis, and the other is triple approach, where you take abdomen, right thorax, and left neck. If I want to remove full esophagus. Okay, half esophagus, 60-70% esophagus, I can remove by Ivor Lewis. But अगर पूरा esophagus निकालना है, then obviously I have to go all the way till the neck also. There is no choice. I have to go till the neck. ठीक है? ये हो गया esophagus. Now answer this question. ये वाला came just now. This exam. See, these kind of questions come, in surgery, and students say, "Sir, I missed by 4-5 marks." Why should you miss? You know what you should think. If out of this year in surgery there were about 35 questions. The students who learned from me, what they said, they said that of these 35 questions, I got 28 questions right. I got 30 questions right. Just imagine, if you can get 30 questions in surgery right, from all the other 18 subjects, you need to get only 120, 125. The burden that will reduce is enormous. And surgery questions are standard questions. You don't have to mug too much. Very normal questions. Clinical, no doubt, but if you understood the topic, abhi aise question mein you cannot make a mistake. Patient comes with progressive dysphagia, initially to solids, now to liquids, significant weight loss. What is the investigation of choice? Okay, investigation of choice. What are you thinking if he has progressive dysphagia and initially to solids? So you are thinking of esophageal mass, significant weight loss. This is pseudoachalasia. You will do endoscopy with biopsy. Investigation of choice, endoscopy, biopsy. Simple. There was no manometry also to confuse you. Endoscopic ultrasound, barium swallow, CCT. These will be done in Zenker's diverticulum. This is not Zenker's. Dysphagia कहाँ है Zenker's में? Endoscopic ultrasound is for staging. So how would you get this wrong? ऐसे क्वेश्चन आते हैं. आ गई बात समझ में? अभी वाले पेपर का क्वेश्चन है ये, just now. It is there on the app also. I have recorded all these questions if you want to see them on the app. And this question came. Best investigation for GERD. FMG June 2022. Best investigation. It is 24-hour PS study. If the question was first investigation, then you would mark endoscopy. आगे बात समझ में? ऐसे सोचना है क्या मुश्किल है? my students should get 28 to 30 questions out of 35 questions in surgery. You should say, surgery is what saved me. So many students told me this time, surgery is what saved me, because the first half, the first 150 questions, they didn't do well. Second half, surgery, OBGY, they did very well. So, yeah, these are recall questions. They are there on the app also. If you want, you can see all the FMG questions I have discussed. ऐसे होना चाहिए. Surgery should rescue you. They are not very easy, but they are not the most difficult. I think at least you won't have to mug too much in surgery because they are clinical subjects. तो ज़्यादा रट्टाबाजी की जरूरत नहीं है. Now come to stomach. First disease that you should study in stomach, बहुत बार पूछा है, that is infantile pyloric stenosis. Infantile pyloric stenosis means when the child is born, there is a hypertrophy or a thickening, hypertrophy or thickening of the pylorus. Which muscles of the pylorus? Mainly the circular muscles. So when I see the stomach, this is how the stomach is. Here there is a sphincter, pylorus. This sphincter becomes very thick, thicker and longer. So what will happen is when the child will feed, so whenever he takes the milk doesn't pass and then he throws up the milk. उल्टी होती है उसको. And this leads to gastric outlet obstruction. GOO. So what is pyloric stenosis? It is a tightness of the pylorus leading to gastric outlet obstruction. This pylorus is gastric outlet, so he'll keep throwing up. When will this child present? And what is the correct name of the disease? Is the correct name, or you must have read some other name? Like you said, achalasia cardia. What book? Yeah, congenital. So in the books, you will hear congenital pyloric stenosis. Congenital means born with it. But let me tell you, it is not congenital. Infantile is correct. That's why I wrote infantile. Bailey Mate is given infantile, IHPS. The child will present not at birth. He will present usually between 4 to 8 weeks after birth. And what will he have? The mother will say, every time I feed the child, the child vomits. What vomit? Non-bilious vomiting. Non-bilious means no bile. Bile कहाँ से आएगी? Because bile comes in the duodenum. Bile cannot go in the stomach. It is non-bilious. जो भी दूध पिलाती हूँ, दूध की दही जम जाती है और वो दही की उल्टी करती है. He vomits curdled milk. And after vomiting, the child is hungry again. वापस वो फीड लेता है, उल्टी करता है, फीड लेता है, उल्टी करता है, फीड लेता है. So the doctor will think, okay, 1 month old child. Usually it is seen in boys more than girls. Boys are unlucky. There are more diseases in boys than girls, unfortunately. Cancer is also more common in men. So it's not immediate. It's within few minutes, 5 minutes, 10 minutes, the child will vomit. The child is hungry again. Now the pediatrician, when he will examine the child, pediatrician or neonatologist, he will notice two things. The first thing is when the child is given a feed, so on feeding, he will see visible peristalsis. And this peristalsis will go the way it is in the stomach, from left to right. So ऐसे होगी ना अंदर distended stomach, बड़ी ऐसी stomach है, distended, and here the pylorus is there, very thick pylorus. So when the child is given a feed, you will see peristaltic waves on the abdomen because the stomach will try to push the milk in front. That is the first thing the pediatrician will see. The second thing that he will see is when the child is relaxed, he is quiet. Okay, he is relaxed, quiet. You can feed him if you want, but more important, he should not be crying. He should be relaxed. The muscles should be relaxed. You will feel the lump in the right hypochondrium. So you will feel a mass, olive mass in the right hypochondria. Okay, if you are reading the notes, if you are, and in the notes it is written unfed, don't write unfed, put it as relaxed. That's the correct word. In a relaxed child, whether he is fed or not is not important. He should be relaxed. He should not be crying. आपने feed किया और वो रोने लग गया उल्टी कर करके, then you can't do it. So this is the word that is given in Bailey, relaxed child. Or fed child. एक बार वो संतुष्ट है, he is happy. That's when you can feel the mass in the right hypochondrium over here. So clinically, pediatrician will know, yes, it is a pyloric stenosis. Very easy to diagnose. The problem is, since the child is vomiting, the first thing you are going to do is you will do a blood test. What blood test will you do and what will you see? In the blood test, something very typical is seen. बहुत बार पूछा है MCQ. Classical. So you will do blood test basically to look at his electrolytes. Since the child is vomiting acid, HCl. When you do his electrolytes, what you are going to see is you will see low chloride, you will see low potassium, and you will see alkalosis. Hypochloremic, hypokalemic, metabolic alkalosis. When you will check his urine, you get a typical finding which is called as paradoxical aciduria. It's very unique. Okay, the urine will throw acid, which it should not. Ideally, it should not. So you get paradoxical aciduria. To confirm the diagnosis, the investigation of choice is going to be, how will you confirm he has pyloric stenosis? Test of choice. Single bubble sign is not diagnostic. You are going to do ultrasound. And what will you see on ultrasound? You will see thick pylorus. Pyloric stenosis batana na, hypertrophy. You will see thick pylorus. More than 4 millimeters. So the diameter is more than 4 millimeters. You can do X-ray abdomen that you are seeing over here. And you will see a nice big distended stomach on X-ray. This is called as single bubble appearance or single bubble sign. How do you treat it? Further treatment of infantile pyloric stenosis, don't call it congenital. It is infantile. It is seen after 3-4 weeks. It is not seen at birth. What is the treatment? So is it pyloromyotomy or something better? Is pyloromyotomy what you are going to do? Seromyotomy hoti hai. Is it only pyloromyotomy or there is something more? Yeah, Ramstead is the name. Absolutely right. No, correct electrolyte is understood. So the first thing you are going to do is you will stabilize because the child may be dehydrated. So correct his electrolytes. How will you collect his electrolytes? What is the solution of choice? No, it's not NS. It's not NS. You will give DNS with KCl. Okay, this is the fluid of choice. It is DNS with KCl because see, chloride is less, potassium is less. So you have to give chloride in NaCl. So DNS will have sodium chloride, but you have to give potassium also because potassium is not there in NS. Na? DNS में potassium थोड़ी ना है, उसमें सिर्फ sodium chloride और dextrose. You have to give potassium. DNS is dextrose normal saline. After this, you are going to do surgery, which you see in this image. So you are seeing this is the stomach. This is the pylorus. He is cutting the pyloric muscles. That is called as Ramsted's pyloromyotomy. So like you had cardiomyotomy, here you have pyloromyotomy. Simple. Okay, this is the treatment of choice. Have a good look at this image. Why not RL? In children, you want to give fluids containing dextrose. So you will give DNS. Why not cholera saline? Because there is no diarrhea. We'll do dilatation by endoscopy. You can do. If it's a low grade of pyloric stenosis, you can do dilation also. Yeah, Harshit has written it correctly. और जो हर्षित ने लिखा है वो सही है. 5% DNS or 5% dextrose with NS. It is called DNS, FYI. Okay. Pylorotomy and pyloromyotomy are the same. But what am I cutting? I am cutting the pyloric muscles, but I am also cutting duodenal muscles. Okay, because this stenosis is not only in the pylorus, it is also in the first part of duodenum. So it is actually pyloroduodenomyotomy. Okay, it is pyloroduodenomyotomy. Then acid. Bilal, normally तो acid जाता है ना intestine में. Normally your stomach acid will not remain in the stomach, it will go in the intestine. Normally, now it will go a little faster. So okay, no big deal there. ठीक है, आगे बात समझ में. इस पे क्वेश्चन आ चुके हैं काफी बार, तो ये बताइए. Answer this question. Jan 2023, over a year back. So, which of these would not be seen? Presents with non-bilious vomiting is true. Common metabolic condition is hypokalemic, hypochloremic alkalosis is true. You lose acid, you will become alkaline. Choice should be between B and C. Now, actually, B is not fully correct. Nothing is 100% sensitive. But C is a better answer. It is not due to hypertrophy of longitudinal, it is due to hypertrophy of circular muscles. Okay, circular muscles become more involved in pyloric stenosis. Okay, that's the better answer. Okay, now coming to peptic ulcer. What does peptic mean? Anybody knows? Ulcer, you know, ulcer means there should be a tear. Peptic means what? What peptic can? Peptic ulcer disease. Pepsin, yeah, pepsin. So, no, it's not pertaining to stomach. That is gastric, na? That is gastric. Peptic comes from the word pepsin. And what is the role of pepsin? Pepsin क्या करता है? It is produced by the stomach. What does it do? What is the role of pepsin? अरे करता क्या है वो? Yeah, thank you, Anurag. It is for protein digestion. So it will break down your proteins in diet. It will not cause any ulcer. Okay, first and foremost. So it's not going to kill your stomach. Stomach will resist proteins. It will resist pepsin. So this name peptic ulcer, unfortunately, is a misnomer. Pepsin has no role in peptic ulcer, unfortunately. Think like this. Please understand, I can say it in one go, but I want you to understand what's happening. It will make your life more logical. It's not peptic that is causing the problem. It is the acid, HCl. The correct name of the disease should be acid ulcer disease. There is damage to stomach or duodenum, means there will be ulcerations of the stomach, there will be ulcerations in the duodenum due to acid induced damage. So acid is the problem. It is not pepsin, so it is not peptic ulcer. It is acid ulcer. All right. So if there is too much acid, it can harm the stomach or the duodenum. It can cause ulcers. The same way the acid causes GERD, esophagitis, same way acid can cause ulcers in the stomach and duodenum. Why? But who gets it? Who gets these ulcers? What are the main risk factors for peptic ulcers? Don't say stress. Acid induced peptic ulcer. अरे peptic word ही नहीं होना चाहिए. Acid induced ulcer. Peptic. नाम ही गलत है. So the main risk factors, the most important is H. pylori infection. H. pylori normally gets affected or it sits in the antrum of the stomach and it causes many problems. One problem that it will cause is it will increase gastrin. More gastrin, more acid. So it causes increase in acid production. Second thing it will do is it will produce some toxins. Like there is one toxin, it is called CAGA, VACA. ऐसे toxin बना था. And these toxins can cause ulcers. They can also cause cancer. So H. pylori can cause ulcer, it can cause cancer both. So two problems with H. pylori. Other than H. pylori, you can get ulcers because of NSAID, painkillers. You can get ulcers because of what you are going to do in every break, that is smoking. Okay, so these are the reasons commonly that will give you ulcers. You can get ulcers in stomach or duodenum or both. Important reasons here. There are many, there are millions, but these are the ones you should know for exam. Now, what is the basic difference between gastric ulcer and duodenal ulcer, and how do the patients present? Is it a big deal? So many of us get ulcers. How is the person present with ulcer? And how are gastric and duodenal ulcers different? Role of spices not in gastric ulcer, not really. Etiology of PUD and GRD is the same? No, of course not. H. pylori has no connection with GRD. Excuse me. NSAID will not cause GRD. GRD is because of TLOSR. Whatever will call it, cause TLOSR. So the important clinical features are going to be pain in abdomen, usually after meals. Okay. And the other thing is this pain will be periodic. It will come for a few days, then you will be okay. Then another few days, then you will be okay. So it comes and goes, comes and goes. Why is it periodic? Why is the pain periodic? Why is the pain periodic? For some days he gets pain. For some days he's okay. No, it's not peristalsis. It's because the ulcers occur, then they heal. Then they occur again, then they heal. So they come and go. So it is a periodic occurrence and periodic healing. That's why there is periodicity. You will not have the ulcer forever. They come and go, come and go, come and go. It's very classical of peptic ulcer disease. So he gets pain and he can come with some dangerous complications. What are the complications? Dangerous complications of peptic ulcer. Very dangerous. The most common complication is going to be GI bleed or bleeding peptic ulcer. This is usually seen in duodenal ulcers. Or the ulcers can perforate. If they perforate, he will get peritonitis. Both of these are life-threatening complications. And this is also seen more commonly in duodenal ulcers, not so much in gastric ulcers. And the third complication, very rare, is the ulcer can undergo malignant transformation. This is seen only in gastric ulcers. Okay, so either you diagnose the patient in uncomplicated state, or he comes with any of the complications. If he comes with a complication, it's a disaster. Perforation लिखा है, perforation. Okay, perforation leading to peritonitis. So these are the important complications that you need to know. There is a fourth complication. Someone wrote gastric outlet obstruction, not so common. आज के ज़माने में इतना common नहीं. So patient can come with any of these problems. Let's assume he has come with only pain after meals periodicity. What will you do first? What will you do first? Patient comes with pain after meals, history of NSAID use. So please remember, first you will investigate. And you need to do only one investigation. Again, see how easy it is. GIT becomes so easy if you apply common sense. You apply the pattern. You will do upper GI endoscopy. So when I will do upper GI endoscopy, I will see the ulcers. So whether they are in the stomach or in the duodenum or both, I will see with my endoscope where the ulcers are. They may be here or they may be in the duodenum. यहाँ पर भी है, endoscope से दिख जाएंगे. What is the most common site of ulcer overall? What is the most common site? Where are ulcers commonly located? Antrum, duodenum, duodenum, antrum, duodenum. It is lesser curvature. Okay, this is the answer. Lesser curvature. That is the most common site of peptic ulcer. Anyway, so I will see the ulcer. Many times patient, okay. But I don't want to only know ulcers. I want to know, is there H. pylori? How do I diagnose H. pylori infection? ये कोई बताए तो मैं मानू, बिकॉज एंडोस्कोपी में अल्सर तो कोई भी देख सकता है. यूरियस ब्रेथ टेस्ट, नो यू डोंट डू यूरियस ब्रेथ टेस्ट. You do a test using antral mucosal biopsy. So you take biopsy from the antrum over here. So H. pylori is diagnosed on antral biopsy. So you see the antrum, and from the mucosa, you take a few pieces of the mucosa and you put it on this slide. This slide is called rapid urease test. RUT. उस पे लिखा हुआ है rapid urease test. So you take a biopsy with the help of endoscope, take a piece of the antrum and put it on the slide. So when I put it on the slide, if the slide becomes pink, it means there is H. pylori positivity. Simple. But please remember, this is not breath test. This is RUT from antral biopsy. आप लोग जो stain लिख रहे हैं ना, Warden Starry, that is histopathology. That will take 2 weeks. You don't need to do that. This is done immediately. Within 5 minutes, you will know if there is H. pylori or not. आगे बात समझ में? What I want you to understand is this is done endoscopically from the antrum. You take biopsy from the antrum. Why do you take from the antrum? क्यों antrum से? Antrum में क्या खास बात है? RUT is written over here, rapid urease test. That is what it stands for. Yeah, it is where H. pylori stays. It is not the site of the ulcer. It is the site where H. pylori hides. It hides in this antral mucosa. That's why. Okay. आगे बात समझ में? All very, very, very important things that you must know in context of peptic ulcer in terms of diagnosis. Last part is easy part. How will you treat someone with peptic ulcer? Why it hides there? इसका ना Nobel Prize मिली है जिसने H. pylori diagnose करा. It was found in antrum. Commonly it is found. You should ask, why doesn't the gastric acid kill H. pylori? No organism will survive in the stomach except H. pylori. ये सवाल पूछना चाहिए. Flat जगह मिलती है इसलिए. No, it's not. And don't say sorry. I'm just telling you how to think. No, it's not because of acid resistance exactly. But ठीक है चलो. How will you treat it? Again, the treatment is mainly medical. So here also your treatment will be PPI. If he is smoking, stop smoking. Reduce NSAIDs, obviously. And if he has H. pylori positivity, if H. pylori is there, you will give H. pylori eradication. Triple therapy, I'm sure you know. You will eradicate H. pylori. ये तो कोई भी बता देगा, स्कूल का बच्चा भी बता देगा, आपके घर वाले भी बता देंगे, ये हम करेंगे. क्वेश्चन इज व्हेन विल यू डू सर्जरी? आप मेरे से क्यों सीख रहे हो पेप्टिक अल्सर? क्या खास बात है जो आप सर्जन के पास आए हो? रोल ऑफ सर्जरी इन पेप्टिक अल्सर डिजीज. So it's very simple. It's just like GERD. Very simple. You will do surgery where medically unsuccessful. So he takes PPI, but he still gets the ulcers. Medical failure. Second is if he gets complications. I will give you a thumb rule in surgery. Any disease in surgery which has a non-surgical treatment also, your treatment will be non-surgical. You will do surgery only when nothing else works. Like failure of medical management, severe symptoms, complications. This holds good for everything in surgery where there is non-surgical treatment possible. Some diseases you have surgery only, like hernia. In hernia, there is no second option, surgery or nothing. But ऐसे बीमारियों में GERD, peptic ulcer, there are other options. You try other options. Okay? Just because you are a surgeon does not mean everything should be treated by surgery. You think like you are the patient. भाई मेरे को पेप्टिक अल्सर है, then I will not want to undergo a surgery ना. जब तक चल रहा है काम तब तक चलने दो. Appendicitis करेंगे गौतम, तब आप ये सवाल फिर से पूछना. You ask again, गौतम. Now, when do I do surgery? When there is a problem like this, what are the surgeries that I do? It depends on the type of the ulcer. whether it's a gastric ulcer or duodenal ulcer. Here I need to differentiate gastric versus duodenal. So my question is, stomach is producing acid. It is used to the acid. Why is that acid causing ulcer suddenly? Stomach is used to the acid. So why should suddenly that acid cause ulcers in the stomach? Very good. Excellent. Excellent. So understand, gastric ulcers are not because of extra acid. They are because of loss of barrier function, loss of mucus barrier. Stomach produces a lot of mucus that protects it from the acid. So even if the acid is a lot, the mucus will protect it. When this mucus barrier is lost because of H. pylori, because of NSAID, because of smoking, you get gastric ulcers. Duodenal ulcers, duodenum cannot stand the acid. Duodenal ulcers happen when there is extra acid production. आई बात समझ में? ये बहुत इंपॉर्टेंट कॉन्सेप्ट है जो आपको समझ में आना चाहिए, because the surgeries are based on this understanding. How? I'll show you. But please be very clear, gastric ulcers are not because of hyperacidity. They are because of loss of barrier. So, duodenal ulcers, the treatment is going to be acid reducing procedures. Acid reducing procedures will help with duodenal ulcers. Gastric ulcers, even if you reduce the acid, will not help much. Here, the treatment for gastric ulcer is going to be excise the ulcer area. बस उतना ही करना. Excise the ulcer area. You don't have to do any vagotomy. So whatever surgeries I'm going to talk about, vagotomy, pyloroplasty, they are all only for duodenal ulcers. Okay? For gastric ulcer, you don't have to do vagotomy because acid production is not the problem. Acid production is the problem in duodenal ulcers. आई बात समझ में? Okay. I will repeat. Stomach is used to lot of acid. Stomach तो क्या है? It is producing HCl all the time. So this HCl does not harm it. There is a lot of HCl in the stomach. But it will not harm the stomach because there is a mucus barrier which is protecting the stomach mucosa. If I smoke a lot, if I have H. pylori, then this barrier is lost. Then the acid will go and traumatize the stomach and cause ulcers. So stomach ulcers, loss of mucus barrier. But duodenal ulcers are different. If there is too much acid, it will go into the duodenum and this will cause duodenal ulcers. So to treat duodenal ulcers, I will do acid lowering surgeries. For gastric ulcers, I don't do acid lowering surgeries. I just remove the ulcer area. बस और कुछ नहीं. Okay? अब बात ठीक है? Can we give antacids? You can give antacids. You can give. So whatever surgeries I'm going to talk about, acid lowering procedures are only for duodenal ulcers. Okay? Now how do I lower the acid? I have two ways. One way is by doing vagotomy. Because when I do vagotomy, it will reduce acid release. That is one. Second surgery that I can do is what is called as antrectomy. Antrectomy means remove this part of the stomach, antrum. Antrum is the part which produces gastrin. So gastrin release will reduce. If there is less gastrin, there is less acid. So there are two principal surgeries for stomach, for duodenal ulcers: vagotomy and antrectomy. Okay, so we will describe these surgeries a little bit in detail, vagotomy and antrectomy, and what questions can come on them. this पे question आ चुके हैं एक दो बार, थोड़ी अजीब से क्वेश्चन है पर समझ में आ गया ना, रटना नहीं पड़ेगा. परमानेंट गैस्ट्रिन डैमेज नहीं होगा, कम होगा. इट विल रिड्यूस द एसिड प्रोडक्शन. इट विल नॉट मेक इट जीरो नहीं होगा. So what is this vagotomy? Now see this image. This is the esophagus and the stomach. In front of the stomach, you have this anterior vagus nerve. This vagus nerve gives all these small branches. Okay, they go into the stomach and they will control acid release. Similarly, there is a posterior vagus, which also goes into the stomach, the branches, and causes acid release. One of the surgeries that I can do is called a truncal vagotomy. So this is one of the surgeries for peptic ulcer, truncal vagotomy. Truncal vagotomy means I will cut the vagus at the origin, at the trunk. So what will happen is once I cut the vagus here, anterior and posterior vagus, if it is cut here at the trunk, all of these branches automatically go. Automatically the supply is gone. They are disconnected. So the whole stomach acid release will reduce. So when I do truncal vagotomy, there is reduced acid production. But remember what I told you about vagus. What is the other function of the vagus in GIT? What does vagus do? Responsibility, peristalsis, and one is peristalsis. Second function, very good. Opening of sphincter. Excellent, brilliant. So I need vagus. Abhi maine काट दी vagus. Peristalsis will weaken. Pylorus will not open. So the problem is when I do a truncal vagotomy, the pylorus will become like achalasia. The pylorus will become closed. So whenever I do a truncal vagotomy, I have to do what is called as a drainage procedure. क्योंकि अभी पाइलोरिस बंद हो जाएगा तो खाना आगे कैसे जाएगा? एसिड तो नहीं बनेगा लेकिन खाना कैसे जाएगा? So I have to do a drainage procedure. One of the drainage procedures is a pyloroplasty, not pylorotomy, pyloroplasty. So the problem is whenever I do a truncal vagotomy, I have to do a pyloroplasty. I have to do two surgeries in one. Pyloroplasty has complications of its own. So truncal vagotomy with pyloroplasty is not a very easily tolerated procedure. Patient is not very happy because now the pylorus will become very big. Someone was asking, acid will go in the duodenum. It happens here. Acid will quickly go into the stomach into the duodenum. Food will go quickly into the duodenum. He has a lot of problems because the pylorus has become lax. To avoid this extra procedure, there is an alternate to truncal vagotomy. That alternate, which is a better procedure, is called a highly selective vagotomy. It's called highly selective vagotomy. Highly selective. Selective means I am not cutting the trunk. I am picking and choosing the branches of the vagus which I will cut. So here what I do is, I don't cut the trunk. I go lower down and I cut these individual branches. They are cut and here I spare the pylorus. So the nerves which go into the pylorus, they are spared. So in highly selective vagotomy, pyloric branches are spared. They are called the pyloric crow's foot because they look like feet of a crow, are spared. So now what will happen? Acid production will reduce. Not very much, but it will reduce. Pyloric function will be intact. So I don't have to add a drainage. No need to add a drainage procedure because pylorus is intact. So between the two, which procedure has better tolerance? Highly selective vagotomy. Okay, because I will preserve the last 6-7 centimeters of pyloric nerves. So pylorus is intact. Acid production come hoga, not so much, but I don't have to add a drainage procedure. So this has very less complications. This has the least complications and best tolerance. Least complicated, best tolerated. This was asked in FMG. I think 2 साल पहले. that which of these acid reducing surgeries is least complicated. It is this. Yeah, less than 5%. Whereas truncal vagotomy with pyloroplasty has 10% complications. So why would you, when we study now, there are two kinds of people. There are the aggressive people who will try to study everything. So what they have to do, they have to sacrifice their social life, personal life, health, because they want to study. So truncal vagotomy is that person, aggressive person. He will know a lot, acid reduction will be very good, but his mind will get fried. So obviously complications will be more. Highly selective vagotomy are those people who study selective IMP topics, PYTs, PYQs, who attend my class, who are not going to attend very heavy duty classes, simple classes. के surgery में 35 में 25 to 28 questions आ गए. I don't want all 35. 25, 28 questions आ गए. Job is done. So I get some time for myself, for my social life, for my boyfriend, girlfriend, to drink. I am doing highly selective. So what will happen? You're not going to get awesome marks. You'll get decent marks. So acid lowering will be decent. Complications will be very less. So that is the principle of truncal vagotomy versus highly selective. Complications versus benefit. ये आपको बैलेंस कर. लाइफ में भी यही करना है ना, हर चीज बैलेंस ही करनी है. बहुत पढ़ाई करोगे 10 दिन you will do very vigorous intensive academics. You will attend class from 5 p.m. to 2 a.m. 3 a.m. and then the next day you will be in a hangover of class. Why do you want that? कम पढ़ो लेकिन ढंग से पढ़ो. Highly selective vagotomy, I believe that's what should be done. But if you are a truncal vagotomy person, you have all options for that. Yeah. So this is one. The other procedures are the antrectomy procedures. Means you have to remove the antrum. When I remove the antrum, antrectomy brace procedure, it means I will resect this part of the stomach. Antrum is going to be removed. So gastrin will reduce. But after I have removed the antrum, now I have the stomach left over here. I have the duodenum left over here. अब मैं क्या करूँगा? I have to join the two. If I join the two like this, duodenum to stomach, directly, that is called as Billroth 1 procedure, where I am joining gastric to duodenum, gastro-duodenal anastomosis. The problem is, this is a very difficult anastomosis. To pull the duodenum to the stomach, not very possible because duodenum is not very free. So Billroth 1 never took. People were very unhappy. After Billroth 1, it had many complications. So after Billroth 1 came another surgeon who modified Billroth, who said, okay, forget it. Duodenum is not coming all the way up. No problem. Let it not come. I close the duodenum and I take jejunum. Jejunum will come up very easily. Jejunum is very flexible. Like me. Very flexible. क्लास जल्दी करनी है जल्दी करो, लेट करनी है लेट करो, नहीं करनी है मत करो, रोज करनी है रोज करो. Flexible. So jejunum can come up very easily. So you have to decide whether you want to be jejunum or duodenum in your life. And you do a gastrojejunal anastomosis. This is called Billroth 2 or gastrojejunostomy. आई बात समझ में? So Billroth 1 and Billroth 2, the only difference is the anastomosis. Resection is the same. You are doing antrect. How are you joining? Either join stomach to duodenum, जो आज के जमाने में कोई नहीं करता. It is given up because it's not a very easy anastomosis. Gastrojejunostomy is very easy because jejunum is very free. It is in excess. Like people like me are saste, easy to access. So हमको कोई भी चुन लेगा, फिर हमको कोई भी छोड़ देगा. Same way, jejunum can easily be pulled and you can do a gastrojejunal anastomosis. That is Billroth 2. So Billroth 1, gastroduodenal anastomosis. Billroth 2, gastrojejunal anastomosis. Okay, both these surgeries are done for duodenal ulcers. The principle is Andrecht. Why pylorus removed? Pylorus is not the important part. Antrum is removed. Roux-en-Y is similar, but I don't want to bring it here, Gauri. It will only confuse. It's similar. Roux-en-Y is very similar to this. It's ek kadam aage. Okay. So these are the surgeries which are done for gastric and duodenal ulcers that you need to know. Only one last thing I will tell is most tolerated procedure with least complications is going to be highly selective vagotomy, HSV. But if they ask you most powerful procedure, means which procedure will give you maximum acid suppression? What is the answer? Acid lowering सबसे ज़्यादा किस में होगा? Don't say highly selective vagotomy. Yeah? That's not the answer. Billrod 2, Billrod 1, no. See, you use your common sense. Truncal vagotomy will reduce the acid. Antrectomy will reduce the gastrin. What will be the most powerful then? What is most powerful? Combination, yeah, combination. Combination is the most powerful. I will do truncal vagotomy with antrectomy. दोनों भी तो कर सकते हैं ना? Combined. कोई करता नहीं है आजकल ये सब. आज के जमाने में in my whole life I must have seen only 2 truncal vagotomy. बस कोई नहीं करता आजकल. These procedures are not required because PPIs are very good. Luckily, exam में पूछते हैं. इसलिए मैं बता रहा हूँ. HSVs I have written over here ना, highly selective vagotomy. This is HSV. अगर आप ये सब समझ गए ना, आपको कभी लाइफ में कंफ्यूजन नहीं होगा ये सब घटिया टॉपिक्स में. They are not good topics, but they are asked in exams, so you should know. Unfortunately, yeah. What is this little light-headed topic? Yeah, this what you see is a tricho. Tricho means hair. Bezoar. Tricho, bezoar. Bezoar means gola, ball. There are some people who have some psychiatric illnesses who pull their hair and swallow it. So it's a psychiatric illness where you pull your hair and swallow it. And this hair will not get digested by your acid. So it will start collecting in your stomach. And it will form a ball. You can see it has taken the shape of the stomach only. That is trichobezoar. So typically, this is going to be seen in young girls who have psychiatric illnesses. And when you will see them, they will have sparse hair on their scalp. Obviously, they are not going to tell मैं अपने बाल नोच के खाती हूँ. वो तो नहीं बोलेंगे. But when you will see them, they'll have sparse hair on their scalp and they will come with epigastric pain because the ball of hair has gotten collected in the stomach. They'll have epigastric pain, they will have vomiting. And when you will do CT scan, you will see that there is a ball in the stomach. So this treatment is going to be surgical removal. So you do surgery, you open the stomach. After you open the stomach, you will see the ball of hair. You can take out the ball of hair. And obviously, after surgery, you will refer the patient to a psychiatrist. Okay? This was asked a couple of years back. Answer is psychiatrist. Okay, not pediatrician, dermatologist. हाँ, मतलब बाल उगाने के लिए नहीं है. Dermatologist के पास मत भेजना. Sparse hair देख के. It's an illness, and they are not going to tell you कि मैं बाल नोच के खाती हूँ. You have to observe that. आप लोग का ना imagination already Saturday night पे चल गया. Saturday night imagination. Okay, let's move on. Important topic. I feel इसमें से आपके एग्जाम में क्वेश्चन आएगा. Upper GI bleed. Upper GI bleed means what? Where is the bleeding? What is upper GI? खाते वक्त पकड़ना नहीं. No, it's not esophagus, stomach. Upper GI means your GIT has 2 parts. There is esophagus, there is stomach, duodenum, and where the duodenum ends and the jejunum begins. तो यहाँ पे मान लो 4th part of duodenum है, यहाँ पे jejunum. All this is jejunum. Here there is a ligament which is called ligament of Treitz. If bleeding happens proximally, means bleeding happens in the esophagus or stomach from an ulcer or duodenum from an ulcer, it is called upper GI. If it is distally, means small bowel, colon, rectum, lower GI. So upper GI bleed means bleeding that is happening proximal to ligament of Treitz. Okay, are we clear about this? Proximal to ligament of Treitz. Proximal to ligament of Treitz means कहाँ से आ रही है bleeding? The bleeding can be esophageal origin. It can be from the stomach. It can be from the duodenum. These are the locations. Esophagus में क्या है भाई? Bleed होने लायक. What is the cause of bleeding from esophagus? सी कौन सी बीमारी है esophagus में? Which will lead to bleeding? Excellent, excellent. Some of you have given correct answer. One is varices, esophageal varices. See, esophagus can also bleed. In stomach, there are many diseases, but important one is ulcer. Or it can be cancer. It can be a unique disease which is called Mallory Weiss tear. We will discuss this. Okay, don't worry about Mallory Weiss now. We will discuss it. And in duodenum also you can have ulcer, peptic ulcer, acid ulcer. जो भी अभी पढ़ा. From these, which is the most common cause of upper GI bleed? MCQ. Most common cause of upper GI bleed. बताइए. So answer is going to be bleeding duodenal ulcer. Duodenal ulcer is the most common cause. 33% is going to be duodenal ulcer. This is the most common cause of upper GI bleed. Okay. So we will discuss why does it happen and how will you manage MCQs. If the peptic ulcer bleeds, which peptic ulcer will bleed? What is the location? So normally duodenal ulcers will bleed which are in the first part of duodenum on the posterior wall. Posterior wall ulcers are going to bleed. It's like this. See, this is the esophagus and this is the stomach. This is the duodenum. Behind the duodenum, there is one artery which runs on the back side of the duodenum, which goes and supplies the pancreas. This artery is the gastroduodenal artery. नाम में लिखा हुआ है ना stomach and duodenum, gastroduodenum. Ulcer will erode into the gastroduodenal artery. So if my duodenum, if I'm seeing from the side, ऐसा है मेरा duodenum, this is anterior, this is posterior. Okay, this is the anterior wall. This is a posterior wall. And just behind the posterior wall, this artery is running. Gastroduodenal artery. So if I get an ulcer here in the posterior wall, it can go and tear the artery. And then soup karke the artery will start bleeding into the duodenum. Any बात समझ में? That will lead to upper GI bleed. Okay? Which artery is going to be affected? Gastroduodenal artery. So how will the person present and how will you manage? Person will come, he will have some history of peptic ulcer. Like he will say, I was taking NSAID or I am smoker. Uski history होगी. And now he will come with sudden onset vomiting of blood. खून की उल्टी. What is the meaning of vomiting of blood? What is it called? Vomiting of blood. Other name? What is the surgical name for vomiting of blood? Yeah, very good. He will complain of hematemesis. Absolutely right. So the typical history will be sudden onset hematemesis. Any patient who comes with hematemesis, what is the first thing you do? He can have hematemesis, someone, Akash Gupta has correctly written. He can also have melena. That can also be the presentation. Melena means black stools. black tarry stools. Very good. Black tarry. Yeah. Brijban. Yeah, Brijban has come for my classes before. I remember the name. What will you do first? Any patient comes with hematemesis. सबसे पहले, very good Preetham. No, don't rule out TB. First stabilize the patient because you don't know how much he has bled. Na? So first you will stabilize. So airway, breathing, circulation, and you are going to put a Ryle's tube because you want to confirm that he is bleeding. This is one classification of peptic ulcer bleed which is seen on endoscopy. So this is something you need to know over MCQ, but otherwise not that important. That when I do endoscopy, what do I see and what are the severities of peptic ulcer bleeding? So if the bleeding is active, that is going to be 1A, 1B, Forrest classification, where 1A means the bleeding is from an artery, is spotting. So I can see this during endoscopy. That when I did the endoscopy, as a pichkari nikal rahi. That means artery is bleeding. Usually it is arterial, but sometimes it can bleed from the veins. So that is 1V, that is going to be ooze. That means it is venous. This means the bleeding is active. But most of the times when the patient undergoes the endoscopy, bleeding has already stopped. Actually, it has stopped. In that case, you will see some evidence of recent bleeding. Like in 2A, you will see a visible artery. That is 2A, visible vessel. In 2B, you will see a clot. So maybe it bled over here and now a clot is sitting over there. And in 2C, you will just see a little dot. It's called an acid dot. And in type 3, there is no evidence of recent bleeding. We'll just see the ulcer. What is the purpose of this classification? I mean, why do all this complicated thing? If it's bleeding, I will stop it. If it is not bleeding, I don't need to do anything. Bleeding, obviously, I will stop. Why do I need to make all these categories of Forrest? Excellent, excellent. Some of you have given the correct answer. It's not for management. It will tell me the risk of rebleed. Because abhi bleed hua, it may have stopped. But what are the chances that he will bleed again? It tells me the risk of rebleed. As I go from 1A, 1B, 2A, 2B, 2C, the risk reduces. So higher the grade, lower the risk of rebleed. That is the Forrest classification. Okay. How do I see it? It is seen on endoscopy. So Forrest is for risk of rebleed or bleeding peptic ulcers. Okay. आगे बात समझ में? Anyways, so I put a Ryle's tube. After I put a Ryle's tube, after the patient is stable, I will do upper GI endoscopy. And when I do UGIscopy, I will see one of these things. If the bleeding is active, what should I do? No, Forrest is only for bleeding peptic ulcer. It's not for any other bleeder. Only for peptic ulcer. Not for any other. So the best thing I can do if I see bleeding like this or bleeding like this is do something endoscopic. So best thing is what is called as endotherapy. Now endotherapy mein, what all can I put? What are the choices? I can put a clip. So if I see the artery, I can put a clip with the help of endoscope, or I can cauterize it. You know what is cautery? Like you have monopolar cautery, here they use a different cautery. Or apart from clip and cautery, I can inject vasoconstrictors like adrenaline. Most of the gastroenterologists use some of these things for bleeding peptic ulcer. Most of them. Either clip or cauterize or inject adrenaline. If they ask you in the exam which of these you are going to do, you have to do any two of these three. So the answer is going to be dual endotherapy. Okay. So what is the treatment of bleeding peptic ulcer? Dual endotherapy. Please be very clear about this. Okay, not just endotherapy, dual endotherapy. मतलब आपको कोई भी दो चीजें करनी out of these three. कौन से दो करेंगे? It depends. There are many factors decide what you are going to do, but you have to do at least two. Don't just cauterize करके ठीक है बंद हो गया काम हो गया, ये नहीं करना. दो चीजें करना. Most of the times this will be successful. Most of the times. But कभी कभी even after this he may rebleed. तो क्या करोगे? If he bleeds again, then what do you do? ये सब कर दिया, पेशेंट चला गया रूम में, वापस खून की उल्टी हुई. So you can do one more attempt at endotherapy. So basically you can try endotherapy only twice. So you can do two attempts total. One more attempt at endotherapy. And if he still rebleeds, then you have to think of alternate treatments. Okay. फिर भी अगर bleeding हुई, then you are going to do either you do angioembolization. This is done by radiologists. You can angioembolize or you can do surgical control. So this is where surgeon will come. Basically ये सब बीमारियां ना surgical है ही नहीं. They are all managed medically or endoscopically. But when endoscopy is failing, you will think about surgery. Okay, twice. Endoscopy will fail twice. You think of surgery or you think of angioembolization. Angioembolization means you put a embolizing material in the artery. The bleeding will stop. Surgical control means you do laparotomy, see where it is bleeding and you suture it. Surgical control. Okay? So this is how you are going to manage upper GI bleed due to bleeding peptic ulcer. Treatment of choice is going to be dual endotherapy. Now, try this. So, I hope you are going to do this, but I hope you don't get a GI bleed. But I'm sure some of you are going to do this after your exam. ये make नहीं है, this is young male. So not make, this is male. Passed his exam, FMG mission 200 crossed. He went for a party, he had 10 beers and he presented with vomiting and upper GI bleed. What is the cause? What is the answer? Mallory V stare. Okay. So the answer is Mallory V stare. But what is Mallory V stare? Mallory V stare is a tear in the cardia of the stomach. Okay, normally it is in the stomach cardia. So it is a tear in the cardia of the stomach. It's only a tear, it's not a perforation. Only the mucosa tears. So only the mucosa will tear. And this will lead to bleeding. And what is bleeding? Submucosa. So the mucosa will tear and the submucosal veins will bleed. So stomach is like this and the bleeding happens over here, cardia of the stomach, just below the GE junction. Why is it happening? This is happening after repeated vomiting. So अगर आप बहुत बार उल्टी करो ना, you keep vomiting, retching, stomach will keep contracting, then the mucosa tears and he starts getting hematemesis. It happens after multiple vomiting episodes. The typical history is you drink a lot, you get intoxicated and you start vomiting, and one fine time you start getting blood in the lungs. That is Mallory V stare. Okay, any problem with this? Please don't confuse it with DU bleed. After binge drinking, what you are going to get is Mallory V stare. How do you manage this? Why not perforation? Perforation में blood नहीं आता ना. In perforation there is no blood. In perforation he gets peritonitis. So what will you do? You will do endoscopy to confirm the diagnosis. And usually the bleeding is stopped. Usually nothing is required. You just do surveillance. If it's bleeding actively, you can do endotherapy. But if the bleeding has stopped, just observe. It stops on its own most of the times. Okay. Please understand, in perforation, he will get peritonitis, not bleeding. In pancreatitis, he will get pain, not bleeding. In a Boerhaave, he will get chest pain, not bleeding. Bleeding is seen only in Mallory V stare between the four options. Okay, no. Boerhaave is very different. Don't confuse it with Boerhaave. In Boerhaave, there is an esophageal perforation. तो Boerhaave में क्या होगा? This is the esophagus. Okay, and here is the diaphragm. In Boerhaave, he vomits against a closed esophagus or a closed cricopharynx or closed glottis. So यहाँ पर होती है ना cricopharynx. It is closed. It does not open when he vomits. So when he tries to vomit, all the contents get stuck in the esophagus. They don't go out into his mouth. And because of this high pressure, the esophagus tears over it. So there is a perforation at the esophagus. Left lower esophageal perforation. Okay, it's not bleeding. It has torn in Boerhaave. और वो फूट गया. If there is a tear, all the contents will leak into the chest. So this person will not present with bleeding. He will present with mediastinitis. So what he will have typically is going to be chest pain. He will have vomiting. And sometimes the air also leaks into the chest wall. That is called as subcutaneous emphysema. तो कभी कभी ना उसके चेस्ट वॉल में एयर होती है, subcutaneous emphysema. Anybody knows what these three are called together? Chest pain, vomiting, emphysema in Boerhaave syndrome. Binge drinking का history होता है, yes, होता है. This is called as, yeah, very good, Himani. It is called as macular striae. Okay, this is called as macular striae. Both these things, Boerhaave and Mallory-Weiss-Stare, they will happen after binge drinking, after vomiting. But in Mallory-Weiss-Stare, there's a tear. So there is a hematemesis. In Boerhaave, there is a perforation. Transmural, फट गया esophagus, and things are leaking. So you will have mediastinitis. Okay, they are very different. This has to be treated by surgery. The treatment of Boerhaave is going to be surgery. Any perforation you will do surgery only, na? अभी सब esophagus से leak हो रहा है, you have to do thoracotomy, see where it is leaking, and you have to suture it. आया बात समझ में? So Boerhaave, not tear, Boerhaave perforation. Okay. Borchardt triad was somewhere else. That's in gastric volvulus. Okay, don't mix it with that. In Boerhaave, what will happen is he tries to vomit, but this is closed. The sphincter, cricopharynx is closed. So the vomit collects in his esophagus. It does not go out. So the esophagus distends and it bursts. It bursts over here. Pura esophagus nahi phutta, it bursts over here. And because it bursts, the contents in the esophagus go into the chest. That is Boerhaave. Okay, अब समझ में आया Boerhaave? Now you will not confuse it with Mallory-Weiss-Stare. Close होने का reason alcohol intoxication. Is intoxicated, so the sphincters don't open. दारू बहुत बुरी चीज है, बहुत प्रॉब्लम होती है उससे. Okay, fine. We'll proceed. You're good till here. To peg is good. Yeah. जब ये बंद कर दी, अच्छा काम किया. बहुत नेक काम किया. Anyways, so no hematemesis. There is no hematemesis in Boerhaave. There is macular striae in Boerhaave. And the treatment is going to be for Boerhaave surgical repair. It's not going to be endoscopy. Endoscopy नहीं करते हैं perforation. You will do surgical repair. What bleeds in Mallory-Weiss-Stare? Submucosal veins. लिखा है मैंने submucosal veins. अगर mucosa फटेगी, then the bleeding will be from submucosa. Mucosa में blood vessel नहीं होते, submucosa में. Mucosa is just a layer. Okay. If it is closed, how can we see the vomiting? You don't always see it. If it opens, you will see the vomiting. Jiva has asked a legitimate question. How are you seeing vomiting? You may see it if it opens or it may be seen afterwards, after it has all perforated. There would be hematomesis in DU perforation, obviously. Upper GI bleed means hematomesis. How do you know it's perforation? How do you diagnose Boerhaave? Anybody? Investigation of choice for Boerhaave? पता कैसे चलेगा? She's asking correctly. How do you know that the esophagus has burst? Don't do endoscopy. Endoscopy नहीं करेंगे. Another thumb rule: whenever you don't know the answer in surgery, answer just these two letters. CT. Okay. Investigation of choice. It will be CT. So perforation, CT. X-ray कर सकते हैं, but it will not confirm perforation. So investigation of choice will be CT. Okay? Easy topic about peptic perforation. We'll do this and I'll give you dinner break. ये 5 मिनट में हो जाएगा, फिर आपको break दे दूंगा. So peptic perforation. It's an easy topic. Ulcers in the duodenum, which were on the back side, posterior, they were bleeding. Anterior duodenal ulcers. Anterior D1 ulcer can perforate. So ulcers on the anterior wall of duodenum means ये वाले ulcer. If there is an ulcer here on the anterior wall, there is no blood vessel in front of it, so it will burst full thickness and it will perforate. And when it tears, contents will start leaking out and he will get peritonitis. So this is easy. The ulcer will perforate in the duodenum and the person will get leakage of contents leading to peritonitis. How will the person present clinically if he has peritonitis? What is the presentation? Why not option C? You're still stuck on option C. In DU perf, which we are doing just now, you will see there is no hematomesis. Why not option C? Abhi kar rahe na DU perf. So here also patient will have history of peptic ulcer disease. And now he comes with, now it's important over here, he will come with acute abdominal pain. The typical presentation will be acute abdominal pain. He may have vomiting, maybe. And when you are going to examine his abdomen, abdomen will be like a rock. There will be cardboard rigidity. Obviously, if all the contents leak into the abdominal cavity, the abdomen will get inflamed. It will become rigid. So the abdomen, when you will touch it, it will feel like a rock, ekdam tight, because the whole peritoneum is inflamed because of peritonitis. So this is like very easy. Even a nurse can diagnose this, not a doctor. Right? For all scenario, we will do endoscopy, but here it's an acute presentation. So you cannot do endoscopy. Endoscopy has to be done in a stable patient, not in a patient with mediastinitis. You can do it, but it will not give you the diagnosis. Right? So patient comes with cardboard-like rigidity, acute abdominal pain, tight abdomen, history of peptic ulcer. You don't even need any investigation really. Yeah? It's a clinical diagnosis, but nobody does it like that. Patient comes like this. First, you are going to stabilize. Then you are going to do X-ray abdomen with chest. In the books, they say erect, but many times he will not be able to stand because he has so much pain. So many times erect X-ray is not possible. Many times. So you do X-ray abdomen, you see this. What do you see in this X-ray? क्या दिखता है इसमें? So very classically you will see it. This is the right dome of the diaphragm. This black thing below the right dome of the diaphragm, it's air. Okay, you don't see any air under the diaphragm. Here also you can see this is the left dome of the diaphragm. And this little black thing over here is the air. This is not the air in the diaphragm, this is in the stomach. So what you are going to see is free air under diaphragm or pneumoperitone. So X-ray will show pneumoperitone. How much air should be there? to call as pneumoperitoneum? How much air is missed? अगर 1-2 ml air leak हुई तो दिखेगा क्या? What is the minimum quantity of air to be seen on X-ray? The answer in Bailey is 10 to 20 ml. कम से कम उतनी air होनी चाहिए to be seen on X-ray. If I see X-ray with pneumoperitoneum, so if pneumoperitoneum is seen, then what do I do? If pneumoperitoneum is not seen, then what do I do? ऐसा करोगे ना, ये क्वेश्चन में कभी कंफ्यूज नहीं हो. If I see free air like this X-ray, what do I do next? If I don't see free air but patient has rigidity, what do I do? अब आपकी ना थोड़ी बत्ती जल रही है दिमाग. Okay, if I see free air means X-ray is like this. I don't need to do anything. I will straight away do surgery. What do I do in surgery? I open the abdomen, and what I'm going to see is I will see a hole over here in the anterior wall of the duodenum. So what I need to do is this hole that I see, I suture it and I put omentum on top of it. So there is omentum over here. I take some omentum and I reinforce the perforation with the omentum. This omental repair is called as Graham's omental patch repair. So I use omentum as a patch. This is called as Graham's omental patch repair. Okay, it is done for duodenal perforations. So you suture the perforation and you place omentum on top to reinforce it, to patch it. So this is the treatment for DU perforations. What if I don't see air? I am strongly suspecting, but X-ray में नहीं दिख रही है. Maybe air is very less. Then what should I do? To confirm, yeah, then I will do CCT. Okay, this is the investigation of choice for pneumoperitoneum. But do I need it in every patient? Answer is no. I don't need it. Only if X-ray does not show air, I will do CT. Then if CT shows air, I will do surgery. I have no doubt in this. This is how surgeons actually do it. So if anyone tells you anything differently, like ultrasound or all, please don't do it. Don't need ultrasound. If clinically it's a perforation, X-ray, CT. Okay, that is the pathway. Ultrasound will just waste your time. No, RR में है, if you are unsure of the diagnosis, like you think it is pancreatitis or you think there are gallstones, तो ultrasound कर सकते. अगर rigidity है, तो आपको ultrasound की जरूरत नहीं. So answer this and then take dinner break. Okay, answer this and then take dinner break. This question also came in FMG. So what I need you to focus here is not the X-ray, is patient taking regular NSAID should give you the clue. He will not have abscess or cholecystitis. NSAIDs can cause pancreatitis, they can cause, but not so commonly. And what you're going to see here is the free gas under diaphragm. You will say, sir, ये कैसी X-ray है? It's such a dirty X-ray. Exam X-rays are just like this. Okay, they are as dirty as this image. So don't say hard to decipher. Don't rely on the image. Take help of the history. Okay, given in the question. That's my message. Now let's move on to carcinoma of stomach. What you're going to realize is all cancers in surgery will become so systematic and clear that you would be like, I hope cancers come and questions on cancer come, because they will be done very methodically. All cancers that we will study will be done in the same way, especially GI cancers. So I will GI cancers, bad cancers, right? Poor prognosis, they are going to present late. What are the risk factors for CA stomach? Most important risk factor that you already studied is H. pylori. Okay, because it produces those toxins. So H. pylori can increase the risk of adenocarcinoma. Apart from this, smoking, of course. Alcohol, not so much, but smoking definitely. And there are dietary carcinogens like smoked foods. Okay, so there are some dietary carcinogens like smoked foods, soy sauce, which is consumed a lot in Japan and Japanese population, which is why CA stomach is quite common in the Japanese population. That's why they do a lot of screening for CA stomach, right? And obesity. So obesity will increase the risk of stomach, esophagus, as well as colorectal cancer. So सारे के सारे GI cancers में obesity आती है. Then there are some pre-malignant conditions of CA stomach. Any one that you know, any pre-malignant condition. One is gastric ulcer that you just studied, peptic ulcer. Then certain kinds of stomach polyps like adenomatous polyps. When we study colonic polyposis, that time we will study adenomas in detail because they are very important in colon. And then some types of gastropathies like atrophic gastritis or hypertrophic gastritis, but they are quite rare. Atrophic and hypertrophic gastritis, not so common. Yeah. So these are some of the risk factors. Then you come to pathology, just the way you did in esophagus, same way you will do in stomach. But in stomach, pathology is little more detailed, little more. Yeah. So pathologically, stomach cancer is divided into two parts: early gastric cancer, advanced gastric cancer. What is the most common site of stomach cancer? Most common site? Esophagus was middle esophagus in India and lower esophagus in Western world. Similarly, here also most common site will be antrum worldwide. So worldwide it is antrum. But proximal stomach in the West. Anybody can tell the reason? Don't say obesity and giardia. What is the reason? Proximal stomach in West and antrum in uh, worldwide or in India. Smoking will affect full stomach. No, because H. pylori affects the antrum. And H. pylori is the most important risk factor. In Western countries, H. pylori you get from water. So in Western countries, water will not have H. pylori. So H. pylori is not so common there. So antral cancers are not so common. Okay, that is the reason. So stomach cancers can be divided grossly into early and advanced. Early is given by what is called as Japanese classification. And early, there are types, but simply remember early means the depth of the tumor is mucosa and submucosa. Bus. It is not deeper than that, which means it is either T1A or T1B tumors, non-muscle invasive. Advanced is given by Borman. You may have heard of this in pathology. This is Borman. And this is going to be T2 or more. Means muscle invasive. And this is divided into exophytic. So you can see the image. Exophytic means the tumor is growing outwards into the lumen. This is ulcerative. The tumor looks like an ulcer. Then this is a mixed picture. Ulcero infiltrative. And the fourth one is the diffuse type, also called as Linitis plastica. What is the purpose of this Borman classification? ठीक है ना? Exophytic, ulcerative, infiltrative. What's the big deal? Why are we making these categories? Or whenever you see any classification, no, you should ask yourself, कि भैया इसका use क्या है? Is it helping me in any way? Like how Forrest was telling you, the lower you go, the less the rebleed. कुछ reason था? इसका क्या है? No, it's not going to affect the management. Nothing to do with the management. Unfortunately. No, this will differ in behavior. The behavior will be different. If the tumor is growing into the lumen, exophytic, this tumor will have more chance of bleeding. Because it is growing into the lumen, it will start tearing and it will bleed into the lumen. So GI bleed, exophytic. If the tumor is ulcerative, it will cause more of a pain after meals. It will behave like an ulcer. So you'll have pain after meals. If it is the infiltrative type, it will cause obstruction, like gastric outlet obstruction. And if it is diffuse type, or you were saying leather bottle stomach. Diffuse type means stomach will become like this. The tumor will infiltrate the wall like this. So stomach will become like this. It will become a shrunken stomach. So this person will have early satiety. Okay, this will have early satiety because the stomach has become like a leather bottle. What I'm trying to tell you is this pathology has a bearing on the behavior of the tumor. If you notice in esophagus, you had exophytic tumors, you had ulcerative tumors. So the presentation was dysphagia. Dysphagia kab hoga? When it was infiltrated. GI bleed kab hoga? When it is exophytic. So tumor behavior is based on the tumor pathology. Same will hold good even when you study colorectal cancers tomorrow. So ye yaad rakhna. All tumors behave based on their pathology. So stomach cancer can present with any of these ways. So now when I study clinical presentation, clinical features, the first thing you should see is it will be an elderly smoker man. In your exam, whenever you see elderly smoker man, think of cancer. And he will present with any of these. Either he will present with bleeding. So he may have hematomesis. Or he may have melena. Or he may have occult blood in stools. Occult means it will not be seen. But he will become anemic. Pata nahi chalega, but when you do stool test, you may see blood in his stools. Or person can present with pain after meals. He can present with non-bilious vomiting because of obstruction, early satiety, same things. Or he can present with metastasis. Stomach cancer has a lot of metastasis. It can spread to adjacent organs, aspas. So adjacent organs means it can go to the pancreas. Stomach के पीछे होती है pancreas, or it can go to colon, and so on and so forth. Not that important. It can go to lymph nodes. Many lymph nodes are there draining the stomach, or it can go hematogenously. Where will it go? Hematogenously? CS stomach. कहाँ पे जाएगा? Hematogenous metastasis of stomach cancer. Yeah, normally it will go to liver via the portal vein. So the veins of the stomach, they all eventually go into the portal vein. The veins of the intestines, they all go into portal vein. That's why stomach cancer, colorectal cancer will all go to the liver because of the portal vein. So the cancer cells will go from portal vein to the liver. There are some special metastases, like there can be Furcow's node. You know what is Furcow's node? It is a left supraclavicular node, enlarged left supraclavicular lymph node. There can be Krukenberg tumors. Someone wrote in the chat also. So these are all special metastases, Krukenberg tumors. They are bilateral ovarian tumors. So these are some kind of metastasis, special metastasis that is seen in CS stomach. Now, any patient who comes with these kind of symptoms, what are you going to do first? If you want music, I can play music after 10 o'clock. Yeah, not before. So Janvi ma'am has a short subject, so she can easily take music and dance. I will tell her, but not in my class. Surgeons don't dance. Surgeons will make you dance. Furcow's node is left supraclavicular node. So stomach cancer can spread to the left supraclavicular node also. It happens. Any patient with upper GI symptoms, elective patient means non-emergency. First investigation, which is also the investigation of choice, is going to be upper GI scopy, where you will see a tumor like this and you will do biopsy. So where is this tumor? If you can understand the location of the tumor, what is the location? Yeah, Virchow is not Virchow, it is Furchow. It's for Furkow, Furkow. It's a German name. It's not Warchow. Huh? Warchow mat bolna. Why are you saying antrum? All of you have written antrum. So obviously this is the tumor. But why are you saying antrum? The location. ऐसा क्या है उसमें लिखा थोड़ी है कि वो antrum है. Yeah, excellent. This hole that you see now, this small hole, that is the pyloric opening. And beyond that is the duodenum. The first part of duodenum is beyond that. I'm telling you because these kind of images get asked. So if you use little common sense, little awareness, you will be able to identify what's going on. This is the area before the pylorus. This is the antrum. So you do biopsy. What do you do after? You come to know that it is adenocarcinoma of the antrum. What will you do next? ठीक है ना, एडिनोकार्सिनोमा. अब क्या पेशेंट को बोलेंगे चलो सर्जरी कर लें, आ जाओ, let's do gastrectomy? No, thank you. For all those of you who gave the answer, you have to stage. Means you have to look for metastasis. And you have to look for two types of metastasis. Local metastasis means depth of invasion, for which you will do endoscopic ultrasound. Same that you did for esophagus, EUS. And for distant metastasis, you will do PET scan. See, your life will become really easy if you follow basic surgical principles ना, oncosurgical principles. पूरी onco surgery ऐसी ही चलती है. तो सोचना नहीं पड़ेगा. You get an MCQ where they say 60-year-old smoker male came with weight loss and early satiety. Endoscopy showed this mass. Biopsy was done showing adenocarcinoma. What is the next step? Don't answer gastrectomy. Okay, don't answer gastrectomy. Answer staging. So you are going to do staging, local staging with EUS, endoscopic ultrasound, distant metastasis by PET scan. Okay, so that is the answer. After doing all this, you will see the TNM staging. Okay, you will see the TNM staging. Now I will tell you the T staging. T1, A, B, T2, T3, T4. Okay, T4 as A and B. And recall what you saw in esophagus. Okay, it's very similar. Not that difficult. GI organ इतनी ही तो है, उन सबकी layers भी same है, तो staging इतनी अलग नहीं होगी. I'll show you esophagus का staging, then you will understand what I'm trying to say. See over here, this one. Mucosa, submucosa, muscularis, adventitia, resectable, unresectable. This is esophagus. Now see stomach का staging. Very easy. When we do colon and rectum, even easier. There are just some tricks that you need to know, which nobody tells you. Because they will tell you tricks which will help you mug everything. I don't want you to mug. I want you to use some common sense and application. Not very difficult. T1A is the same, tumor up to mucosa. T1B is the same, tumor up to submucosa. T2 is the same, tumor invading muscularis. ठीक है, ये तो सेम ही हो गया. T3, now stomach has a serosa. So T3 is tumor invading subserosa. This is extra. In esophagus, there was adventitia. Here it is subserosa. T4A is going to be serosal breach. And T4B is going to be adjacent organs. ठीक है, आया समझ में? इतना ही अलग है. So the different part is only this. N is the same, M is the same. So when you study staging of esophagus, immediately you should study staging of stomach. Immediately you should study colon and rectum, which I will show you tomorrow. And you will realize the similarities and the ease with which you will remember. In fact, this whole staging, this whole T staging is the same. Now, consider yourself lucky. It is the same for colon and rectum. Okay, are you happy? So the T stage of colon and rectum and stomach is the same. Now don't say, sir, how many TNM stages you have to remember? At least GI organs you know, right? So you do the staging, TNM staging. Now how are you going to treat the CA stomach? What is the treatment? Gastrectomy, D2 lymphadenectomy, partial, subtotal, total, surgery, chemo. So treatment for any cancer is going to depend on the stage. You will divide it as early, advanced, or locally advanced, just like you did before, and metastatic. So tomorrow when we do colorectal cancers, all this I will not even say. I will assume that you know, because you should know, because it's the second cancer. Early, what are you going to do? Surgery, followed by, if required, chemotherapy. Advanced, you will give neoadjuvant chemotherapy so that it becomes smaller, it gets downstaged, and then you will do surgery. Metastatic, you will do palliation. So simple. The beauty of oncosurgery is you can study it in the same system. And if you follow the system, it all becomes mathematical, जैसे स्कूल में पढ़ते थे वैसा हो जाएगा ऑन्को सर्जरी अगर ये सिस्टम समझना है और ये सारे कैंसर में आप अप्लाई करोगे व्हेन यू विल स्टडी ब्रेस्ट कैंसर इट विल बी द सेम वे अर्ली लोकली एडवांस ब्रेस्ट कैंसर मेटास्टेटिक ब्रेस्ट कैंसर पूरा टीएनएम की जरूरत नहीं है ये सिस्टम पता होना चाहिए तो देन यू टॉक अबाउट द सर्जरी तो क्या क्या सर्जरी करेंगे अभी स्टमक में अप्रोच तो एक ही है obviously entire stomach is in the abdomen so you will do laparotomy इसमें नहीं है Ivor Lewis Pewis lucky and the second is how much are you going to resect so to resect the stomach you are going to do 5 centimeter margin okay again this is 5 centimeter but more important is the proximal margin distal margin depends on the location of the tumor don't worry about it but you are going to do section with 5 centimeter margin. Okay, esophagus 10 centimeter, stomach 5 centimeter. When we do other cancers, I will tell you uska bhi resection margin. But in principle, 10 for esophagus, 5 for stomach. Now in stomach, what you need to know is you are going to remove the lymph nodes. So sometimes they ask you what lymph nodes are you going to remove? The types of lymphadenectomies. ये थोड़ा पता होना चाहिए थोड़ा कठिन है पर अपन सिंपल करेंगे okay 5 centimeters both by some sources is not very correct because antrum you can't go 5 centimeters distally because you will go into the duodenum that's why so you can remember it 5 for both but it's not real now lymphadenectomy means when I'm going to remove the stomach cancer around the stomach there are lymph node groups which are numbered like somewhere here is going to be number 1 to the right of the cardia this is going to be number 2 to the left of the cardia this is going to be number 3 to the lesser curvature here will be number 4 greater curvature then 5 will be above pylorus 6 will be infrapyloric so these are some lymph node groups around the stomach all these lymph nodes around the stomach are called as perigastric nodes peri means near gastric means near the stomach perigastric means lymph nodes near the stomach which have to be removed beyond this the blood vessels of the stomach also have some lymph node groups okay so stomach has a very rich blood supply you don't need to know details of that but there are all these lymph node groups around the stomach little away so you have lymph node groups like you will have number 7 over here then you will have number 8 over here you'll have number 9 over here little away and you'll have 10 and 11 near the spleen so these group of lymph nodes are little away if I only remove the lymph nodes near the stomach सिर्फ इतने just on in the vicinity of the stomach perigastric that is called as D1 lymphadenectomy D1 means perigastric nodes are going to be removed perigastric means lymph nodes from 1 to 6 so I remove the stomach with the tumor and I remove the lymph nodes around the stomach okay I remove the lymph nodes around the stomach But they realized this is not enough. You should also remove these lymph nodes which are a little away. So remove 1 to 6, but additionally also remove 7, 8, 9, 10, 11. So थोड़े दूर आते हैं, which are in a little distant arc. These also should be removed. So when I say D2 lymphadenectomy, I remove perigastric and I remove higher lymph nodes, means which are more distal. Means I'm going to remove 1 to 6 plus 7 to 11. Okay, this is what is done normally. D2 lymphadenectomy. So D2 means 1 to 6 and 7 to 11 also. It is not 7 to 11 only. Like in some places, some non-surgeons will tell you it is 7 to 11. But that's not correct. It is 1 to 6 and 7 to 11. Means 1 to 11. तो उसमें कंफ्यूज नहीं होना. खाली बाहर के लिम्फ नोड नहीं निकालोगे, पहले तो घर वाले निकालोगे, फिर घर के बाहर के निकालोगे. So it is 1 to 11, not only 7 to 11. वो mistake नहीं करना. I know where these wrong things have been taught by non-surgeons about this lymphadenectomy. Please don't follow that. If you have those notes, you can change them there also. How do we know where are the lymph nodes? Lymph nodes are along the blood vessels. Okay, they are along the blood vessels. So when I'm resecting, I see the artery. On the artery, the lymph nodes are present. So I remove the artery and the lymph nodes on the artery. Lymph nodes are not hanging in the air. They are hanging on the blood vessels. So they are supported by the blood vessels. Okay. So when I say D1, I am removing only these 1 to 6. घर के आसपास के. And when I say D2, I remove घर के आसपास के means 1 to 6 और थोड़ा दूर. That is 7 to 11. So this is D2. Don't worry about D3. Nobody does D3. So for stomach, I do gastrectomy with D2 lymphadenectomy. That is the standard of care for CS stomach. Yeah. And then the chemotherapy for CS stomach is called as FLOT regimen. You can write it down. F stands for 5-fluorouracil. L stands for leucovorin. I don't know if you've been taught this in pharma or not. O stands for oxaliplatin. And T stands for taxane. These are chemotherapies which is used for esophagus and stomach both. Even in colon and rectum, it's very similar. ये जो नाम है ना, platinum. When you see platinum, it's one of the most important chemotherapies for GI cancers. Esophagus, stomach, colon, rectum, anal canal, even hepatobiliary cancers. Platinum group of drugs are used very common. It's the, you can say the basal chemotherapeutic agent in a lot of chemotherapy combinations. Okay, yeah, cisplatin bhi hai. So, alag combinations are there. That is about CS stomach. Okay, answer this. What is the name of the, so this was asked. PYQ. So it is Borman for advanced CS stomach, muscle invading. Japanese is for early. What is Dukes? Dukes क्या? What is Dukes? Yeah, very good. Dukes is a staging for colorectal cancer. What is Lauren? Lauren क्या है? Lauren pathology में पढ़ना चाहिए आपको. What is Lauren classification used for? Breast adenocarcinoma. No, someone wrote it correctly. It is for microscopic types of CS stomach. Okay, it is microscopy of CS stomach, not gross appearance. It divides CS stomach into some early type and advanced type, intestinal type and diffuse type. So that is Lawrence classification. I don't think you need to know it there. Now coming to small bowel, a very interesting disease, intestinal TB. It's not at all difficult, but you know one TB from me, you can use it to all the other tuberculosis in the whole body. एक ही principle है for all the extrapulmonary tuberculosis. एक वो प्रिंसिपल समझ गए ना, तो when you will study pot spine, when you will study genitourinary TB, it's the same. That's the beauty. It's like a cancer, kind of. So when you study intestinal TB, first you need to know is it is most commonly going to affect the terminal ileum and the cecum, basically IC junction. That is the site where you will normally get intestinal TB, terminal ileum and cecum. Okay, it can happen anywhere in the whole of the gut, but typically ileocecal junction is the site of intestinal TB, and this is usually going to be seen in people who have exposure to the bacilli. So people who have had a pulmonary TB in the past, or people who are living in unhygienic, undernourished environment. So people like you and me should not be getting this. Really speaking, our immunity is good, but people who are undernourished, poor socioeconomic status, they are the people who will get intestinal TB. Okay, ideally not you and me, unless we have a period where our immunity falls. होता है कभी कभी. Which viral infection happens because of decline in immunity? Which viral infection happens? HIV. No, it does not, because of decline in immunity. No. HIV happens because of transmission. The छोड़ो नहीं आ रहा आपको. It is herpes zoster. So you have chickenpox virus inside you, and when your immunity drops, you will get herpes zoster. That is similar to TB. So the thing about TB is it is there in all of us, at least who are living in India. It is there, but it's not causing any problem. When will it cause problem? So how will TB reach the intestines? It will reach the intestines by two ways. One is I have a pulmonary TB and I swallow the sputum. So मुझे खांसी आती है, I swallow the sputum, and from there it will reach the intestine. Or second way is I have pulmonary TB and it enters my bloodstream, and hematogenously it reaches the intestine. So normally TB will always go by one of these two pathways. We have it in the lung, and from lung it will go to the intestine. It will not straight away drop into the intestine. It's not a primary TB, it is a secondary TB. पहले के जमाने में you could have gotten primary because of Mycobacterium bovis, but आजकल नहीं होगा. It will always be secondary. Means it should be there in our lungs first. That gone focus should be there. Okay, so either you swallowed the sputum which had the bacilli, or the TB from the lung entered the blood, and from blood it reached the intestine. So this is all secondary, it's not primary. Now once it reaches the intestine, it will normally reach the IC junction. That is the best site. It loves going there. And at the IC junction, what it does depends on the person's immunity. Okay, it depends on the person's immunity. If the person's immunity is poor, which is seen in most of the cases, then what the bacilli will do is it will cause ulcers in the ileum. That is called as ulcerative tuberculosis. So you get ulcers in the ileum. You know those typical ulcers which are perpendicular to the length, transverse ulcers. Those ulcers happen. If the immunity is medium, good, or moderate, it's not a poor immunity, it's a moderate immunity, then what will happen is the body will try to control the bacilli. It will not let the bacilli multiply. So to keep it controlled, what it will do is it will cause a lot of fibrosis, a lot of inflammation. What is this called? What will happen over there then? If there is a lot of fibrosis and inflammation, ulcer नहीं होंगे, inflammation and fibrosis होगा. Granulomas तो सारे TB में होगा. All TB will have granulomas. No, it will not cause stricture. No, absolutely wrong. What it will do is the cecum, the terminal ileum, will all become very thick. It will cause a ileocecal thickening. The ileum, cecum, ascending colon will all get constricted. This is called as hyperplastic cecal tuberculosis. So the first thing you need to understand is TB of the intestine will either be ulcerative or it will be hyperplastic cecum. Depends on how his body reacts. Body reacted well, it will all become constricted, fibrosed, inflamed. Body didn't react well, it will cause ulcers. And दोनों में आपको ग्रैन्युलोमा तो मिलेंगे यार, ग्रैन्युलोमा तो सारे टीम में, ठीक है? ठीक है, टीबी हो गया, क्या बड़ी बात है? Is it going to kill him? Can any of this kill him? Is it life threatening to get intestinal TB? Is it life threatening? इतना हम टीबी के पीछे पड़ते हैं. No, yes, of course, yes. Both of these, in fact, more in this, you can get some complications. Complications are important. हमने जो भी डिजीजेस पढ़े हैं ना, उसमें हमने कॉम्प्लिकेशन की वजह से उसको भाव दिए है. पेप्टिक अल्सर परफोरेशन, GERD Barrett's esophagus, GERD hiatus hernia. So here also complication. What complications can happen? Obvious ones. Any ulcer can perforate. So like your DU perforation, you can get ileal perforation. Or the ulcers can form a narrowing or stricture. So you were saying stricture before. Stricture will happen when the ulcers will fibrose, not in this hyperplastic cecum. And if they form a stricture, person will get intestinal obstruction. आई बात समझ में? This is the most important part that you need to understand, that it can just remain as an ulcer, or it can perforate, or it can cause obstruction. Why will it cause stricture? It's because of this. See, the ulcers are like this. They are transverse ulcers. They are perpendicular. So when they will heal, they will narrow the lumen. So these are the sites of the strictures. Which ulcers are along the length? कौन सी बीमारी में you get ulcers along the length, and that's why they never form stricture. पता होना चाहिए. All this is basic pathology. Excellent. Typhoid. Ulcers and typhoid will never form stricture because they are along the length. So even if the fibrous narrow नहीं हो, they can perforate, but they will not form stricture. अब समझ में आया क्यों? It's because of how they are located. Anyways, so person with intestinal TB can have any of this, either uncomplicated or complicated. How will he present clinically? So clinically, if he has only ulcers, what will the ulcers do? The ulcers in the ileum will irritate the ileum, and because they are irritating, the person will get diarrhea. It's one of the common findings. He'll have diarrhea, he may have pain, and very rarely the ulcers will bleed. Bleeding is not so common because they are not so deep and they are chronic. So bleeding is not so common. They can cause ulcers, they can cause pain. If there is hyperplastic cecal TB, how will this present? जिसमें ileum is pulled up, cecum is tight. Constipation, melena, no. They will present with lump in abdomen. Okay, so they will present with lump in abdomen. There will not be diarrhea. Constipation is not a specific finding. Typically, the mass will become very tight. So it will present with a lump. And of course, if he has complications, like he has a perforation, then to khalas, he will present with peritonitis, rigidity. So when you see peritonitis, free air under diaphragm, it's not always DU perforation. Huh? It can be TB, typhoid perforation also. Or he can present with obstruction. So he can present with vomiting or distension of abdomen, and so on and so forth. So the presentation of TB is very variable. That's why it's not very easy to diagnose it. आप suspect ही नहीं करोगे. These are such non-specific symptoms. Anybody can get diarrhea. So many of us get diarrhea, constipation, non-specific things. So if it's ulcerative, you can expect diarrhea. If it's hyperplastic, where the cecum, terminal ileum are all constricted, fibrosed, they become a mass. So you'll have a mass in the right side, or you can come with any of the complications. Let us assume person is coming with diarrhea. which is a common presentation. It's an early finding. How will you investigate? Cocoon abdomen is a very late stage, Srishti. It will come much after. So it's a very unusual presentation. So any patient with lower GI symptoms like diarrhea, the first investigation is going to be stool. First you check the stool. So you do stool routine microscopy. What will you see? Will you see the bacilli in stool routine? You will do ZN stain of a stool. So you may see pus cells. Occult blood not so common. You may see pus cells, but you will not see any organism. So you will not see any E. coli or amoeba, nothing of that sort. But pus cells will be there because of ulcers and inflammation. What will you do next? If he is uncomplicated, if he is only having diarrhea, uncomplicated, he has diarrhea or he has lump, what are you going to do? X-ray. X-ray पे diarrhea में कुछ नहीं मिलेगा. Pus cells, because there is inflammation, na? It's a hypersensitivity reaction, granuloma. So you will see. So person is having diarrhea, lower GI symptoms, you will do colonoscopy. And on colonoscopy, you will see the ileal ulcers. And what should you do when you see the ileal ulcers on colonoscopy? What should you do? Ulcer दिख गया, अब क्या करूँगा? Very good, excellent. You will do biopsy. And the biopsy will show you granulomas with caseation. So you'll see granulomas with caseation, with the giant cells, and whatever you see in the tubercular granulomas. But I can do colonoscopy only if he has come with diarrhea, pain, lower GI symptoms. If he comes with perforation, obstruction, I cannot do colonoscopy. Okay, I cannot do colonoscopy. So if person has come in complications where it's either obstruction or perforation, first I will do X-ray abdomen. And then I will do CT abdomen. Okay, I'll do X-ray and I will do CT. Because if he's obstructed, I will have to do CT. If there is a perforation, I will see it on X-ray. आई बात समझ में? So whether you do CT or colonoscopy depends on the presentation. Be very clear about this. Please don't reverse it. Acute abdomen, you will not do colonoscopy. Acute abdomen, you will not do endoscopy. Acute abdomen, you will only do imaging because he may not be stable. Okay, so to do any endoscopy, he has to be stable. What will you see on CT? And पहले के ज़माने में they used to do this image. Anybody can tell me what is this image? What is this image? Which will tell you some evidence of tuberculosis. पहले करते थे, आज नहीं करते. आज CT पे देखते. So in olden days they would do barium meal follow through. BMFT, barium meal follow through. आजकल करते हैं CT. And you would get some typical findings. Like what you see in this image, you can see normally cecum should be right side, ileum should be here. ऐसे होती है normally, cecum and ileum. What you see here, IC junction has gone up. Ileum is coming from down. It's a little unusual, no? How come IC junction has gone up? So unusual. So what you see in this image is called as pulled up cecum. So the cecum IC junction have gotten pulled up. Like how you saw in hiatus hernia, G junction got pulled up, here IC junction has gotten pulled up, like hiatus hernia. So there is a pulled up cecum. And you see this narrowing over here. जो आप लोगों ने chat में लिख दिया, that is called string sign. String sign of Cantor. These findings are also seen in Crohn's disease. If in medicine, if sir teaches you Crohn's disease, the signs are the same. So this imaging is not specific of tuberculosis. These kind of findings can be seen in Crohn's disease also. Crohn's also affects IC junction only. Okay. So you get some evidence of tuberculosis in the abdomen on imaging. So basically, to summarize, someone asked me to summarize. Patient comes with diarrhea and abdomen is otherwise okay. You will first do stool test. Stool may show pustules because there is inflammation of the intestines. Then to confirm, you will do colonoscopy with biopsy. On colonoscopy, you will see ulcers in the ileum and cecum. ऐसे वाले अल्सर दिखेंगे, उनका biopsy करोगे, biopsy will show granulomas, caseation, Langerhans giant cells, all that will be seen. So you know ASTB. If he comes with obstruction or perforation, you cannot do endoscopy. You will do X-ray and then you will do CT, and based on that you will manage. Okay, X-ray or CT may show free air. Obviously, if there is free air, TB हो कुछ भी हो, आपको तो free air manage करना है, perforation manage करना है. But if it is uncomplicated, you can diagnose it on colonoscopy. ठीक है, आई बात समझ में? Is that fine? For the person who asked me to summarize it, I hope I have summarized it clearly now. Last part is treatment. Treatment is very easy. If it is uncomplicated, what are you going to do? If it's complicated, what are you going to do? It's uncomplicated, only one thing. He has diarrhea, ulcers, whatever the hell, you will give ATT, anti-tubercular therapy. And if he has any complication, obstruction, perforation, stricture, you will do surgery. बस so simple. अभी तक हमने जो भी बीमारियां करे हैं ऐसे ही तो करे हैं. If it is uncomplicated, medical management. If it is complicated, surgical management. Same thing over here for TB also. How is it difficult? If there are no problems, please don't do surgery. Okay, please don't do surgery. If it's perforated, you suture the perforation. If there is a stricture, you do stricturoplasty. So surgery depends on the complication. Like if there is a stricture, you will fix the stricture. That is called stricturoplasty. If there is a perforation, you will close the perforation. It's not omental patch. Huh? Omental patch is only for duodenum. Okay, don't say omental patch Graham's closure. That's not over here. That's for DU ulcers, DU perforations, not for TB. Okay, all right. So that is about TB. I think it could not have been put in a more simplistic manner. And now, if you read it once, सब दिमाग में बैठ जाएगा. Okay, answer this. So again, I want you to focus not on the answer but on the question. That there is a 38-year-old patient. Since 1 year, she's having constitutional symptoms. So it's a long-standing history. There could have been diarrhea also in this patient. There could have been obstruction also. But what you are seeing is this narrowing, pulled up IC junction, dilated ileum. So this is going to be ileocecal TB. If ileocecal TB was not there in the option, could it be anything else? After surgery, ATT, obviously, na, TB ka has to ATT. Yeah, excellent. I'm happy with the answer. If this is not there, go for Crohn's. Okay, they are technically the same. Tuberculosis of the intestine and Crohn's, they are the same. Only treatment is different. सिर्फ treatment अलग है. TB you will give ATT, Crohn's you will give immunosuppression. Otherwise, they are the same. They have the same presentation. Okay. Coming to some easier things now in life, because only 15 minutes more and then you will be done. So coming to little easier things, I will always keep easy things for the end now. So when you start seeing easy topics, you can take a little sigh of relief. Acute appendicitis. Who gets it? This is seen in youngsters, not like you, even younger than you. It is seen in teenagers. ओके आपसे भी छोटे. आप लोग का बर्ताव टीनेजर जैसा ही है. आपके जोक्स तो स्कूल वाले ही है, लेकिन आप में टीवी नहीं हो, आप में अपेंडिसाइटिस होना नहीं चाहिए. This is seen in teenagers. Usually it is seen more in boys. The ratio is 3:2. And it is mainly because the appendix, for some reason, so appendix is over here, SO the appendix. It's a diverticulum from the cecum. Cecum se nikalti hai. There is an appendix like this, and this is the opening of the appendix. For some reason, the appendix gets blocked. It is called obstructive appendicitis. it gets blocked over here. Why it gets blocked? There are many reasons. It can get blocked because of hypertrophy lymphoid follicles. So it can be because of hypertrophy. यहाँ पर pairs patch होते हैं ना IC junction में, दिएगा hypertrophy. So hypertrophy of lymphoid follicles. Or it can be because of worms, which can go and block over there. Or it can be because of polyps, tumors, or fecolith. Fecolith means it's a mass of feces. Fecolith. कुछ जाके वहां पर उसको block कर देगा. If it gets blocked, then it will start distending and get inflamed. That is acute appendicitis. 90% of appendicitis happen like this, obstructive. Non-obstructive appendicitis बहुत ही rarely होते हैं. Okay, बहुत ही rarely होते हैं. If the patient is old, then it is carcinoma. Absolutely right. Elderly patient with appendicitis, you will think of appendicular neoplasm. Absolutely right. बिल्कुल सही. But it's not a very common disease in elderly. Now, how will the person present clinically? Very important, very basic clinical findings. History में he will have triad of appendicitis, which is called triad of Murphy, where he will have pain in right iliac fossa, and this pain may have migrated. It can be a migratory pain, means it started in the umbilicus and then migrated to right iliac fossa. So teenager with right iliac fossa pain, acute onset, is going to be appendicitis. He will have vomiting or nausea. Someone has written, I woke up during my appendicectomy. I wonder why. Was it laparoscopic appendicectomy or open appendicectomy? वो कौन सी anesthesia थी? Okay, and he will have low grade fever. This is a typical presentation. Sometimes the person will have some other findings also, like when you are going to examine him, he will have this tenderness at a very typical location in the right iliac fossa. What is that area? So if you join this line from umbilicus to anterior superior iliac spine at 2/3 distance from the umbilicus, somewhere here, 2/3 from the umbilicus, he will have tenderness. That is called tenderness at McBurney's point. That is one of the typical findings. McBurney point tenderness. If you read the books, they will give you many named clinical findings which are not so important. The important one is McBurney's tenderness or tenderness at McBurney's point, and he will have a finding which is called as rebound tenderness, which is also called as Bloomberg sign. बस ये दो ही याद रखो, Bloomberg sign, rebound tenderness, tenderness at McBurney's. बहुत सारे हैं अपने काम की. Patient comes with this, what will you do first? How will you investigate? If a patient comes with these findings, right iliac fossa tenderness, clinical. So clinical पहले के जमाने में करते थे, आजकल you will not diagnose it clinically. If the patient is a young patient, typically a child, the investigation of choice is going to be ultrasound. And it will tell you inflammation of the appendix. The appendix will look very thick and inflamed. So the thickness of appendix will be more than 6 millimeters. It will be thick, it will be inflamed. In an adult, you are going to do CCT abdomen. Okay, that is the investigation of choice for an adult. So ultrasound may diagnose it, but in an adult, better to do CT because he may have a tumor, right? Or he may have appendicular lump. So that's how you will diagnose it. Last part is treatment, which first you tell me this, then we'll go to treatment. Which of the below incisions is preferred for open appendicectomy? Preferred पूछा है ना? So preferred is going to be this. What is the name of this incision? What is the name of this incision? No, it's not Lanz. Lanz nahi hai wo. This is called MacArthur's incision. Why is it preferred? It is on McBurney point, but it is a MacArthur. Name is MacArthur. Why is it preferred? Yeah, excellent, excellent. It is because it is a muscle splitting incision. If they ask you most cosmetic incision, that is going to be Lanz. That is skin crease incision. So most cosmetic incision is the Lanz skin crease incision. Okay? That is going to be appendectomy ke incisions. Nowadays, everybody does laparoscopically. Nobody does open appendectomy normally. Basic question: any patient with appendicitis, the treatment of choice is appendectomy. So, if patient comes with appendicitis, the treatment is it appendectomy? Is that the treatment? What is the treatment of choice? Because someone was asking me this: is the only treatment appendectomy? GridION and MacArthur are the same, my dear. They are the same. MacArthur and GridION are one and the same. So the treatment of appendicitis is, if it is uncomplicated, means patient is stable, the treatment is going to be antibiotics. If it is complicated, like appendix has become perforated, gangrenous, then the treatment is going to be appendectomy. आई बात समझ में? So it is not that appendicitis ka only treatment is surgery. Antibiotics is the treatment of uncomplicated appendicitis. Appendectomy is the treatment of complicated appendicitis. Okay, clear? And the last part is, there is a phenomenon which is called appendicular lump or appendicular phlegmon. कभी कभी होता है. It's basically your body trying to protect the appendix when it has become very inflamed. So कभी कभी ना, when the appendix is very badly inflamed, or maybe it has perforated, what will happen is the omentum will go and cover the appendix. It will not let the inflammation spread, forming a mass. So your omentum policeman will go and cover the appendix, forming a mass, a gola. You can even palpate it. It is a palpable finding, appendicular lump. इसमें appendectomy करना बहुत मुश्किल, because appendix is covered by omentum. So I will have to first remove the omentum, find the appendix and remove it. So इस scenario में क्या करेंगे? इस scenario में what is done is called as Ochsner-Sherin regime. Okay, it is called as Ochsner-Sherin regime. Ochsner-Sherin regime means you are going to do non-operative management. So if patient comes with appendicular lump, you would just keep him nil per oral, give him IV fluids, give him antibiotics, and you monitor the lump. Means monitor the patient, see that he is okay, he should not deteriorate. If he is okay, you will do a appendectomy later, after 4 to 6 weeks. So if he remains okay, he doesn't deteriorate, you will do appendectomy later. What is this called? After 4 to 6 weeks. This is called as interval appendectomy. So the role of interval appendectomy is an appendicular lump. Someone asked this question, interval appendectomy kya hai? It is done when he has a lump and he won't do it immediately. If he is stable, if he is surviving, he is not deteriorating, let it be. He is happy, you are happy, you can do it later. Okay, fine. So we'll stop here. Anybody wants to clear anything can clear it now. You can ask, I'll try to solve 1 or 2 doubts and then the rest we can continue tomorrow. Alvarado nahi puchenge. Lance you will take, Mantral they will not ask, they should not ask. Lance is normally going to be taken in the skin crease over here. जो आपकी स्किन क्रीज होती है ना इंफ्रा abdominal, वहां पर आप स्किन क्रीज इंसिशन लेंगे, that is lens. Okay, answer this and I'll tell you a little bit about dumping. NPO means nil per oral. NF नहीं है वो, IV fluid है. It's not NF, it is IVF, IV fluids. Please stay tuned for tomorrow's class. I have requested them for 3 o'clock. If they permit me for 3, then I'll take start at 3, which is what I would prefer. How much pressure increase during Zenkers? It cannot be measured because it varies from person to person. Okay, so site of maximum pain is going to be McBurney's. Okay, not umbilicus. Umbilicus pay it starts, but it migrates to right iliac fossa. I will tell a little bit about dumping. One boy was asking. It's a very easy thing to understand. Put it in a simple way. Put it here. What is dumping? So dumping is going to be seen whenever you do any surgery, by which any stomach surgery, if you do, you can get a theoretically there is a risk of dump. How pressure decrease cause EOF pressure increases. I don't know what that means. Sir, idea of incision time. Yeah. So I'll tell you about dumping. Whenever I do any surgery where stomach is operated, like let's say I did Billroth 1 or Billroth 2. Let's say I joined the stomach to the jejunum. I did a gastrojejunostomy. Now what will happen is whenever he eats his food, it will not stay in the stomach because now there is no pylorus. This anastomosis is open, so food will quickly go into the jejunum. It will get dumped into the jejunum. And because it is getting dumped into the jejunum, two things can happen. The first is what is called as early dumping. In early dumping, early means it typically happens within 10 minutes. This will happen if he has food which is very rich or very high osmolar, hyperosmolar food, like a milkshake, Coca-Cola, food which has a lot of osmolarity. So when this osmolar food will enter the jejunum, it will suck the blood into the jejunum because of its osmolarity. So jejunum will suck the blood into it. So whatever fluids, plasma is there in the blood, it will get sucked into the jejunum. And because of this sucking of blood into the jejunum, the person will get hypotension because his intravascular volume will reduce. So he will become hypotensive. And because of hypotension, he will feel dizziness. He may faint. He may have bloating because the jejunum is distended. He may have diarrhea. This is early dumping. Why has he got an early dumping? Hypotension. On the other hand, there is a late dump. This will happen 1 to 3 hours after meal. In this, what will happen if he has something very sweet, like mithai, or again milkshake, very sweet milkshake, limbu pani with a lot of sugar, then what will happen is this hyperglycemic food will get absorbed very quickly, and because of this, he will have an insulin spike. So he eats food which is very sweet, it goes into the intestine, it gets absorbed, and it causes an insulin spike. Now this insulin spike will give you a rebound hypoglycemia. So his sugar will suddenly fall. So it's funny, he has eaten something very sweet, but he is getting a fall in sugar. He is getting hypoglycemia, like what some of you must be getting now. It's because of insulin spike. So early dumping is because of hypotension. Late dumping is because of hypoglycemia. So he'll get symptoms of hypoglycemia. So he will get palpitations, whatever neuroglycopenic symptoms, palpitations, tremors, and so on. Yes, that is dumping. Simple. Okay. If patient had acute episode and presents to hospital, are we going to go? No. You will do Ochsner Sherin only if he has a lump. Otherwise, you're not going to do Oshner-Sharon. Okay, let's be very clear. Oshner-Sharon is only if he has a lump, appendicular lump. Sweating is seen in what? Early or late. Sweating is very non-specific. It can be seen in either, but more in late. Neurogleukopenic. Don't worry about sweating. There are telltale ones, which I have told you. Those are the typical ones. Okay? So, see you guys tomorrow. Stay tuned for the time of tomorrow's class. Yeah? Please be aware of that.